Наш мир не стоит на месте. Он стремительно развивается и дополняется новыми данными. За 5 лет человечество произвело информации больше, чем за всю предшествующую историю. Прямо сейчас мы становимся свидетелями развития компьютерных технологий, освоения космоса и инновационных открытий в медицине. Современный образовательный процесс требует от специалистов постоянного совершенствования, в том числе и в вопросах научно-практической квалификации. Возникает острая необходимость в независимой площадке, позволяющей специалистам иметь доступ к передовым достижениям в области терапии. Евразийская ассоциация терапевтов – это уникальный глобальный проект объединения специалистов разных стран и различных областей клиники внутренних болезней, направленный на развитие и совершенствование помощи пациентам терапевтического профиля. Это современная площадка, предоставляющая участникам Евразийского медицинского сообщества доступ к уникальной базе данных, а также возможность обмениваться мнениями и делиться опытом.
Мы объединились здесь, чтобы сложить наши усилия в борьбе за долголетие, процветание народов наших стран.
В Ташкенте открылся 4-й съезд Евразийской ассоциации терапевтов.
В Минске открылся 5-й съезд Евразийской ассоциации терапевтов.
И мы всегда с оптимизмом смотрели в будущее. Нас объединяют общие корни, общая история. И я надеюсь, нас объединяет светлое, большое будущее.
Миссия ассоциации – создание международных медицинских, исследовательских и образовательных проектов между странами Европы, Азии и СНГ. Ассоциация проводит образовательные мероприятия с участием ведущих экспертов. Съезды, конференции, телемосты, школы. Научная программа конференций подготовлена с использованием современных образовательных методик и инновационных форматов. Сегодня ассоциация уже объединяет тысячи практикующих врачей и экспертов из России, Европы, Азии и СНГ. Она помогает совершенствовать медицинские знания и опыт каждый день. Для нас важно сделать процесс медицинского образования непрерывным, современным и максимально доступным. Вступив в ассоциацию, вы становитесь частью глобального сообщества специалистов, работающих под научной и практической составляющей современной терапии.
Good morning, distinguished colleagues. Let me welcome you all on day 3 of our Congress of 10th Jubilee Congress, International Congress of the Eurasian Association of the Therapists. This is a Congress that has main purpose to unite our colleagues, to extend our knowledge, to deep our sharing experience, improve our clinical practice, our routine activities. That's what we are doing daily. Meeting, sharing, discussing our new skills approaches and solutions with our colleagues and with our patients. And definitely today I'm announcing another very busy day that will be completely devoted to most relevant cutting-edge issues of the internal medicine. This day in St. Petersburg Hall, and it is from this hall we are broadcasting today. This is one of the halls of the Congress. Totally, we have 3 of them. So today we are expecting 3 very interesting symposia. First, we start with, that will be symposia devoted to the issues of the diagnosis approaches in patients with chest pain. Chest pain, what we are supposed to do. So this symposia will be completely presented by our distinguished colleagues from Belgrade, from Serbia. And then we will continue a very interesting event for all 3 sessions that would be speed session in Moscow Hall, and that would be presented multiple very short presentations of global experts in these areas, in specific therapeutic areas. This format of the Blitz session. Then next session in St. Petersburg Hall would be continued discussing osteoporosis. And today we finish in this hall with the symposium that will cover the emergency care, especially in terms of COVID pandemic. That's our plan for today. Everybody understands that one of the most important and really relevant options is the option to interact with speakers, the option to provide questions, comments, remarks, to get deeper understanding, clear vision of position of our global experts that are going to speak today, maybe ideas to meet unmet needs in medicine. So please provide your question to the chat, and all our experts will be involved into this discussion during the Q&A time. So after this very short intro, I'm happy to announce the first symposium that we are waiting for, and it's my greatest pleasure to announce the Symposium of Diagnostic Approaches in Patients with Chest Pain, and it's my pleasure to give the floor to Wojciech Giga, who is our colleague from Belgrade, Serbia, who is a doctor of medical science, who is Associate Professor of Internal Diseases Chair, Medical Faculty of Belgrade University, who will present very interesting presentation on the non-invasive testing in patients with chronic coronary syndromes, functional versus anatomical approaches. Voislav, hope you're with us. The floor is yours. Please speak up.
Thank you, Mr. Chairman. First of all, I would like to thank all the colleagues for attending this meeting and also the organizers that gave us opportunity to share our experience and knowledge with you this morning. As we are all aware, in the last 20 years, there is a significant change in the structure of non-invasive test results, with more and more results being negative for ischemia, and rarely, only in some less than 15%, we observe abnormal findings during any functional tests. There are several possible explanations for this phenomenon. First, at least in Western countries, we have the decreased prevalence of traditional risk factors in population, except for diabetes and obesity. Secondly, the increased use of cardioprotective drugs such as statins and antihypertensive drugs, especially in the setting of primary care. Then we have some changes in referral patterns. Basically, more patients with lower pretest probability, those with atypical chest pain, are being sent to functional testing. And even in patients with typical chest pain, we see the lower prevalence of significant coronary artery disease, both in men and in women. Therefore, European Society of Cardiology, basically in the last guidelines from 2019, changed the table of pretest probabilities of obstructive coronary disease from the upper one, typical Diamond Forrester classification, to the new one. When we compare these two tables, we can see that new numbers are significantly lower than previous one, but reflecting the fact that a more or less prevalence of obstructive coronary artery disease. But what is really important is that interpretation of these tables remain pretty the same. So if you have patients with very low pretest probability, those white fields on the upper and gray fields on the lower table, those patients, they don't require any further investigation. Patients with intermediate pretest probability are further evaluated for the chest pain and for the presence of obstructive coronary artery disease. According to the guidelines, if it's possible, it's always better to combine functional testing with some of imaging procedures like stress echo or myocardial perfusion imaging. However, in patients with a lower intermediate pretest probability, those light green on the lower and that light blue on the upper table, those patients can undergo stress ECG, and that's a reliable option for them. However, the new guidelines also introduced the novel thing that's called clinical likelihood of coronary artery disease, and it is increased in patients with traditional risk factors such as dyslipidemia, diabetics. Then if you have a patient with resting ECG changes, LV dysfunction suggestive of coronary artery disease, abnormal exercise ECG, or if you see any calcium on coronary CT. On the other hand, patients have decreased likelihood if they have normal exercise ECG and the complete absence of coronary calcification with Agatston score of 0. After establishing the clinical likelihood of coronary artery disease, we have to decide what to do further with our patient with chest pain to perform functional or anatomical testing. The major trial that assessed prognostic value of these two approaches was the PROMISE trial that involved over 10,000 patients with chest pain and intermediate pre-test probability for coronary artery disease of around 53%. And they were followed up for a median of 25 months for the occurrence of any death, myocardial infarction, unstable angina, or the complications that are related to some cardiovascular procedure. Basically, there were no difference in prognosis between these two approaches, and that's the principal finding of a PROMISE trial. However, we learned several more lessons from the PROMISE trial. First of all, we can see that patients with abnormality either on anatomic testing or on functional testing, those patients have bad prognosis, and the risk of adverse cardiovascular events are about 3.5 times higher in those with abnormal in comparison to completely normal finding. And these data practically confirmed previous knowledge that of higher risk of adverse events in patients with obstructive lesions on coronary CT angiography or in the patients with inducible ischemia on functional testing. However, what is more interesting is that according to PROMISE trial, it seems that patient with negative coronary CT angiography, what does it mean? Basically, the completely normal coronary arteries without any atherosclerosis have 2 times better prognosis than patients with negative functional test. It is of importance that the incidence of adverse events in functional testing arm in PROMISE trial was completely comparable to previously published data on myocardial perfusion imaging and on stress echocardiography. However, what we know when perform functional testing is that we have to interpret the results in the some wider sense and to include also the risk factor burden in our analysis, because patients with very high risk factors burden, those, for example, with Framingham risk category of more than 20%, even after negative functional test, they still have more than 50% of those patients has obstructive coronary artery disease. Therefore, if we include in PROMISE analysis only patients with negative functional testing and very low with Framingham score risk of less than 10%, the prognostic value of that functional test is completely the same as the prognostic value of normal coronary angiography or coronary CT. I'm a doctor that mainly do functional testing. I perform stress echocardiography, and I'm always worried and to see the reasons for adverse event after negative functional test. First of all, we can have a false negative test if we perform stress echo, probably due to submaximal test, then in the presence of single vessel disease, circumflex stenosis. Some medication, especially beta blockers, can alter the ischemic response. If we perform perfusion scintigraphy, you have a problem of balanced ischemia and false negative results in patients with multivessel disease. The second possibility is the disease progression that is responsible for late adverse events, and it's especially relevant in patients with coronary CT angiography. It seems that patients with some kind of atherosclerosis, non-obstructive disease, but with atherosclerosis on CT angiography are more prescribed cardioprotective drugs such as aspirin or statin than patients after negative functional test. And this is one of the explanation for the better outcome in patients undergoing coronary CT angiography in comparison to standard care. It also famous Scott-Hart trial that also compared these two strategies in chest pain patients, but standard care usually comprised of stress electrocardiography. The third possibility is the occurrence of acute events in patients with non-significant stenosis. And really, if we analyze data from PROMISE trial, we can see that the majority of events were in patients with mildly abnormal coronary CT angiography. It means those patients with obstruction less than 69%, between 1 and 69% of stenosis. And really, the data from recent data from 2020 from Scott-Hart trial demonstrated that in patients who have high burden of low attenuation, non-calcified plaques on coronary arteries that are prone to rupture, this presence of that kind of plaques was the only independent predictor of future myocardial infarction. On the other hand, completely clear coronary arteries on CT coronary angiography carries an excellent prognosis and data from PROMISE trial confirmed a negative predictive value of coronary CT angiography nearly of 100%. So in patients with chest pain syndrome, coronary negative finding on coronary CT angio can exclude coronary artery disease in the whole spectrum of clinical likelihood of significantly stenosis. On the other hand, positive finding of stress echo or on functional myocardial perfusion imaging can rule in patients with coronary artery disease with an intermediate pre-test probability of obstructive coronary artery disease. So in the conclusion, we can say that functional testing is preferentially considered in patients with high clinical likelihood of coronary artery disease in whom revascularization is likely. On the other hand, CT coronary angiography is preferentially considered in patients with low clinical likelihood when we want to rule out coronary artery disease and in patients characteristics that suggest high image quality. But we always have to keep in mind local expertise and availability. Perform those tests that you're best in. Thank you for your attention.
No microphone, no sound.
Hello?
Please hold on. So once again, thank you very much, Professor Giga. So from your presentation, we got lots of practical tips and tricks that we will be able to use later on in our practice. So we are expecting Q&A at the very end. And now I'm happy to give the mic to the next speaker. And this is Milorad Cesic, who is also introducing Serbia Belgrade. He will speak about the significance of coronary flow velocity reserve assessed by transthoracic Doppler, a professor, doctor of medical science, and he's introducing Serbia Belgrade. So now we will talk about transthoracic Doppler echocardiography. The floor is yours. Milorad, can you hear us? Please share your screen and unmute yourself.
Yeah,
Belgrade, hello.
I can hear you. I hope you can hear me. Thank you very much. I will share my just a second screen. I hope you can see now. And just a second.
Full screen.
Yeah. It's a little bit slower. Thank you very much again. It's a great honor to be part of this Congress, and my today's lecture will be about the significance of coronary flow velocity reserve assessed by transthoracic Doppler echocardiography. It is known that whenever measured invasively or non-invasively, CFR has been shown to be able to identify patients with myocardial blood flow impairment and to predict prognosis and as well as to stratify these patients. It offers an integrated assessment of epicardial coronary artery stenosis and coronary microcirculation, which are important for tailored stratification in patients with coronary artery disease. According to the expert consensus statement of European Association of Echocardiography, whenever it is possible, it is recommended to perform dual imaging vasodilatator stress echo test. In order to overcome the main limitation of stress echocardiography based only on regional wall motion abnormality, a new standard of practice has been proposed by our Italian friends and colleagues, merging 4 different parameters with different pathophysiological targets. Yeah, that's ABCD protocol. We are trying to implement it in everyday clinical practice in as many as more patients. And A stands for synergy and targets clinical epicardial artery stenosis through regional wall motion abnormality. B lines are B stands for B lines that evaluates pulmonary interstitial edema before and after the test. C is for left ventricular contractile reserve that assesses global myocardial function, and D is Doppler and interrogation of coronary flow, which really integrates both epicardial and also microcirculation. So we can do CFR in everyday clinical practice shortly. CFR, transthoracic Doppler echocardiography, CFR, stands for a ratio between maximum diastolic coronary flow velocity during adenosine and basal diastolic flow velocity, and the normal values are above 2. So according to the physiology, during hyperemia, there is like a term on it was found that the heart is becoming warmer. So the heart with preserved CFR can be referred as a warm heart opposed to the cold heart with the reduced CFR. Most of the time we evaluate left anterior descending artery, but also right coronary artery or proximal parts of the circ might be also evaluated. So we use transthoracic Doppler echocardiography in everyday clinical practice for the functional assessment of intermediate coronary stenosis, follow-up after revascularization, and as well as an additive value of stress echo test, but also to evaluate microcirculation. It was known that there is a great correlation between CFR and diameter of stenosis. Thus, a peak CFR below 2 predicts a significant LAD stenosis with sensitivity and specificity of around 90%, but also with a very high feasibility to do a test. It is a little bit lower for RCA artery and only with slightly lower specificity and sensitivity. But feasibility is a little bit problematic here, and it's from 54 to 86%. In our center, it's like around 80 to 85%. So it was shown even 13 years ago that even a CFR as a standalone technique can be an independent prognostic predictor of outcome, and our Italian colleagues really showed that patients with the preserved CFR had a much better outcome in comparison to those with reduced CFR in patients who has intermediate coronary stenosis, so 50–70%. So even as a standalone method, it was introduced in clinical practice. Later, French colleagues with a little bit different protocol introduced also CFR as a standalone technique, and they input also and they a little bit have different protocol. Patients who had impaired CFR, they had like stress echocardiography, and those who have positive, of course, stress echocardiography, they went to LED revascularization, but those who were negative, they went to a further medical treatment and follow-up. But during a follow-up and with median time a little bit about 1 year, they found out that they had really much more events if they had like a lower CFR in comparison to preserved CFR. Again, they showed that patients with preserved CFR, they have really good prognosis and low event rate. We also showed with a similar protocol that patients after primary PCI, there is a great debate about how to treat non-culprit lesions. So you treat a culprit lesion, but what to do with the non-culprit lesion? So if you have like intermediate non-culprit lesion of LED and RCA artery, we showed again with the longer follow-up to 47 months that also you can really do a deferral of revascularization, and it's associated with low event rate, while the patients with impaired CFR during a follow-up, they have many events. Also, in patients with angiography intermediate or equivocal left main stenosis and preserved CFR values of above 2, even you can use CFR as a standalone technique, so you can safely defer revascularization, suggesting that the CFR might be used as a valuable additional and alternative diagnostic tool in assessing the functional significance of left main stenosis, especially when there is a clinical question of revascularization in patients in whom, for example, FFR is not performed and not available. So you have many clinics that you cannot perform FFR, or they don't have a cath lab. So you can really introduce the transthoracic Doppler echocardiography and help that can help you to make a decision. Also, we found out that during a follow-up in patients with the CFR above 2, there were no documented death or infarcts, but only 6 revascularization during a follow-up of almost 5 years. So again, CFR is coming also in a cath lab. My dear colleague will later have a lecture about invasive strategies in evaluation of coronary stenosis, but you can see that it's a little bit forgotten, the method of invasive CFR, but you can see that patients are doing very good when you have a fractional flow reserve preserved and CFR preserved, but also if you have FFR below 0.80, but still non-stenotic, non-flow stenotic coronary stenosis with the CFR above 2, they're doing good, but those who had involved bad microcirculation, these patients are not doing well, and there was a significantly increased MACE rate throughout 11 years, regardless the FFR cutoff applied. So the influence of microcirculation is underestimated in most of the everyday clinical practice. That's why There is also many studies with more than 1,000 patients, but our Italian colleagues that they really showed that CFR might help you, and that it has an additive value to stress echocardiography test, because most of the time endothelial dysfunction, left ventricular hypertrophy, or the presence of diabetes and the impairment of microcirculation cannot induce the wall motion abnormality, but the outcome is adverse in this kind of situation. So you can see that even those patients, they had, even in these patients who had a negative deep periodontal exercise test, they were really stratified by the value of CFR. One other important thing is about the modulation with medical therapy. So it was known that deep periodontal and stress echocardiography test is hardly modulated with medications, but medication does not modulate prognostic impact of CFR. So it doesn't matter if a patient is on or off of therapy, but if it is a low CFR, there are much more events in comparison to preserve the CFR. So I will just go shortly in which clinical settings you have like impaired microcirculation. It's like many clinical situations, but most often, of course, dilated cardiomyopathy, in diabetes, in hypertension, but also in hypertrophic cardiomyopathy and in patients with syndrome X. They have all impaired coronary flow velocity reserve in comparison to control group, even though they have absolutely like clear coronary epicardial arteries. So shortly, I'll just say that in CFR in hypertrophic cardiomyopathy often is diminished because of the myocardial ischemia that occurs without atherosclerotic coronary artery disease. It's because of the abnormality of the small and partially obliterated intramural coronary arteries, changes in microcirculation, inadequate number of capillaries for the degree of LV mass, higher oxygen demands, that leads, together with some disturbances of coronary flow, that leads to a higher baseline diastolic coronary flow velocity, while similar hyperemia compared to controls, but that leads to the lower ratio of reserve in comparison to controls. And it was a long time shown that patients with impaired CFR have worse prognosis in comparison to those who has preserved the CFR of LAD in patients with hypertrophic cardiomyopathy, match many more bad outcome. Also, in our Italian group also found out that if you have ischemic criteria together with the stress echocardiography, new wall motion abnormality, CFR on LAD below 2, you can see they have much more events in comparison to negative stress echocardiography tests or clinically positive stress echo test. That means that you have positive clinical and hemodynamic criteria, symptoms, exercise-induced hypertension, and exercise-induced left ventricular outflow tract obstruction above 50 millimeters of mercury. So you can also always think about ischemia in this population, which is a little bit kind of underestimated in everyday clinical practice. Also, in dilated cardiomyopathies, you have much more events if you have like impaired microcirculation and impaired the CFR of LAD and the RCA artery, with many more deaths and the progression of heart failure, as well as the implantation of CRT. I would just say at the end that transthoracic Doppler echocardiography CFR is a useful test that gives you a quantitative value. It gives us a number, so it's very easy for us in everyday clinical practice to evaluate the functional status of the coronary artery and the microcirculation. Together with the stress echocardiography test, CFR provides an additive and prognostic information in different clinical settings. The implementation of quadruple stress echo test ABCD protocol, there are potential benefits, and it is extraordinary since it gains the positivity rate and expands the domain of application of stress echocardiography from coronary artery disease to heart failure patients and other clinical settings, and improves the risk stratification potential of stress echocardiography. Also, CFR has a comparative merit of non-invasive evaluation, and it includes wide availability, feasibility, reproducibility, safety, and clinical possibility to repeat CFR evaluation regularly without additional risk of patients. Thank you very much for your attention. Спасибо.
Thank you, Milorad. Thank you. Very interesting. Now we will know that CFVR is everything for us, and you gave us really very practical tool that can be effectively and safely used in our clinical practice. The tool which is feasible, available, cheap, but effective, and we can verify and we can stratify multiple cardiovascular risks in very big group of patients which are frequently underestimated. And this is really very effective and simple tool. Thank you very much. And now I'm happy to give the floor to our next speaker. This is also our colleague from Serbia, from Belgrade. And this is Professor Milan Dobric, who is the interventional cardiologist, and he is working in the Faculty of Medicine, Clinical Center of Serbia, Clinic of Cardiology, University of Belgrade. And the topic of his presentation is the functional assessment of coronary stenosis in cath lab. So those who have cath labs, welcome. Milan, are you with us? Please unmute.
Yes, I'm unmuted. Thank you very much, Mr. Chairman. Ladies and gentlemen, greetings from Belgrade. It is my pleasure to participate at this Congress and to present this lecture about functional assessment of coronary stenosis in the cath lab and what options do we have. As you may appreciate from this very busy slide, we have a wide array of functional and anatomic tests, with diameter stenosis and fractional flow reserve FFR being probably the most validated ones, and the others are put in this complex network along with the studies that investigated the correlation between them. As we talk about invasive functional tests, what do we currently have? We have our old friend, fractional flow reserve. We also have instantaneous flow reserve parameter. We also have some resting, like PD over PA, resting whole cycle index, and the diastolic test indices. Also, as Dr. Tešić told us in a previous lecture, we have coronary flow reserve, which we do not routinely measure in the cath lab, and also hyperemic stenosis resistance, which is a measure of sole influence of the coronary stenosis, but we also, this parameter is not widely used. What is the main advantage of using invasive functional tests? This is because we have a high spatial resolution, sometimes allowing us to determine the individual contribution of individual stenosis, and we also have high reproducibility of this test, which are the features that we do not see that often in non-invasive tests. What is the fractional flow reserve? It's a kind of index that evaluates coronary stenosis in hyperemic conditions. We all know that visual assessment of coronary stenosis is subjective and inaccurate, and FFR was introduced and defined as a ratio of maximal hyperemic coronary flow where stenosis is present, divided by the maximum coronary flow provided the stenosis is absent, which is hypothetical situation or a situation after stenting of the coronary stenosis. In practical terms, this index is calculated as a ratio between whole cycle pressures distal to stenosis at the catheter and the pressure at the catheter tip during maximal hyperemia. This parameter was widely introduced after landmark trials like DEFER, FAME-1 and FAME-2. As you may see in this picture, we have coronary artery stenosis, and simultaneously measure pressures at 2 points, one distal to stenosis, one at the catheter tip during maximal induced hyperemia, usually via intravenous adenosine, and calculate the ratio between of them. You see in this picture a typical presentation of a, let's say, very critical stenosis with the pressure tracings of these 2 points. And in yellow number is a ratio bringing the FFR value. Despite clear guidelines and recommendations, FFR is still underused in many cost to the procedure. There are some technical steps that are critical to making this measurement accurate, which sometimes takes a lot of time, and in every step you may make a mistake. Interventional cardiologists are visual types. They usually believe what they see. They usually think that do not need additional assessment of the coronary stenosis. Sometimes induction of the hyperemia needs time, and it is related to some relatively transient adverse effects like EV block, chest pain, dyspnea, flushing. And sometimes we may also speculate whether this adenosine-induced hyperemia really represents real life ischemia during everyday activities. What about assessment of coronary artery stenosis in basal conditions without hyperemia? It was very early recognized, even by the father of interventional cardiology, Andreas Grunzing, who was the first to measure the coronary pressures proximal and distally to stenosis. But this equipment was a very, let's say, in an early stage, and it doesn't bring high fidelity measurements. So it was not used until the pressure wires were developed. On the other hand, this resting gradient was later reintroduced and again tested, let's say, few decades after this. 8 years before today, let's say, a group of investigators performed mathematical analysis of the cardiac cycle in order to determine the intensity and direction of waves that propagate to the coronary artery during whole cardiac cycle. They identified the part of the cardiac cycle in the middle and at the end of the diastole where these waves do not appear, and name it, let's say, wave-free period. This period starts 25% after the beginning of the diastole and finishes 5 milliseconds before next systole. During this period, microvascular resistance is stable and relatively minimal. It's not absolutely minimal, but relatively minimal. And this brings the coronary transstenotic pressure gradient relatively maximal and allowing us to evaluate coronary stenosis in this period. These lines and these peaks are waves that travel to the coronary artery during cardiac cycle. And as I said, this mid to end 2/3, let's say, of diastole or 3/4 of diastole almost, it's a wave-free period without these waves, allowing us to, by measuring two pressures, derive this functional index. And what is the IFR? IFR is defined as a ratio between distal and aortic pressure during this wave-free period, similar to FFR, but FFR uses whole cycle and uses hyperemia. But the ratio is relatively similarly defined. At the beginning of the investigation of the IFR, first studies aimed to evaluate what was the correlation between gold standard FFR and the new developed index IFR. And initially, they show that there is a high correlation between these indices, and also there is a relatively good classification agreement between these tests. But also, we know that there are 20% of patients that are misclassified with the cutoff values of these tests. Further studies compared IFR with diagnostic performance of PET, single photon emission computerized tomography, hyperemic stenosis resistance, and even show that IFR is better related to CFR and FFR. So it emerged as a promising invasive parameter in validating coronary artery disease. And there is not, as I said, IFR was introduced as a new parameter in order to avoid giving adenosine and to without inducement of hyperemia. But after a few trials were conducted, it led to change in paradigm. It led to paradigm shift. What is the FFR? FFR now we know that measures the impact of coronary stenosis on maximally achieved blood flow in the coronary artery and myocardium, while IFR measures the impact of epicardial stenosis over the depletion of autoregulatory capacity of microcirculation, which brings IFR somehow similar, more similar to CFR, CFR, which has very, very important prognostic information. And taking this into account, we know that correlation is not perfect between these two indices. As you may appreciate from this slide, these are actually two scales. IFR has a cutoff value of 0.89, while FFR has 0.8. Not only they have different values, different scales, but we may also speculate whether they even measure the same value, same physical thing. We know that when you use Celsius and Fahrenheit scales, we measure temperature with both of them, but having different numbers. In this scenario, we have both different scales, but also measure different phenomenon and different thing. The most important trials validating IFR were two great trials published a few years ago. One of them was Define Flare that randomized almost 2,500 patients to the IFR guided versus FFR guided group, and they showed that there was no statistical significance in long-term cardiovascular outcomes. Similar to that and published at the same time was the IFR Svede Heart study, which also randomized about 2,000 patients to this IFR and FFR group. It was a registry-based randomization in Sweden, and they also show that there was no significant difference between outcomes whether you choose the strategy to guide your revascularization according to FFR or to IFR. We know that IFR algorithm calculation of the IFR is protected. You know, it's a kind of intellectual property, and it is not available. You cannot use it. We don't actually know what is the algorithm for calculation. It's a brand name. So actually other manufacturers, apart from Volcano, tried to evaluate their own indices, the hyperemia-free indices, resting indices. And in this very important paper published two or 3 years ago, it was shown that all these diastolic indices, whether you use whole diastole or use 1 point in the middle of the diastole or use calculation in the MATLAB or any other kind of a part of the diastole, you see the almost perfect correlation with the IFR, which led that other manufacturers had a very invasive strategy to promote their indices. So actually in our center we have 4 or 5 different machines that we are able to get these parameters. So if you compare their diagnostic values, we see that all these indices, whatever you use during diastole, has the same diagnostic value as the IFR. Also, this is a receiver operating characteristic curves of different indexes. There is also almost perfect correlation between them. And instead of conclusion, we know that interventional cardiologists now have a wide array of functional invasive tests that we may use to assess significance of coronary artery stenosis. We may choose some of them according to the, let's say, first of all, availability of technical equipment, personal experience of operator, and the angiographic and clinical characteristics of the patients, which may preclude using one over another. And finally, decision to revascularize a patient is always more appropriate to make using non-invasive, or let's say in my story, invasive functional parameters than using angiography only, which is the, let's say, take-home message of my lecture. Thank you very much for your attention.
Thank you very much, Milan. Yes, that's very impressive story. Now we know the valuable tools from the cath labs, interventional tools. And thank you very much for very interesting presentation. And as I said before, we are expecting Q&A at the end. And now it's time for our next speaker. Also from Serbia and Belgrade. Today we have Serbian Day. He is interventional cardiologist as well, and he is introducing cardiology department of Clinical Center of Serbia. He's associate professor and lecturer of medical faculty of Belgrade University. And this is Sergeant Aleksandrich, who will speak about very intriguing topic, myocardial bridging, contemporary approach in the functional evaluation with implications for therapeutic strategies. The floor is yours. Sergeant, are you online? Please share your slides and unmute. Unmute. We can see you, but no sound. Please unmute. Full screen.
Can you hear me?
Positive. Full screen, please.
Okay. Is it okay?
Positive. Please proceed.
Thank you very much, dear Chairman. Ladies and gentlemen, first I would like to thank you for the invitation to give a lecture at your respectful Congress, and I'm honored to be here with you today. I will talk about one congenital anomaly of coronary arteries called myocardial bridging, which diagnostic and therapeutic algorithms are still unclear. Myocardial bridging is congenital anomaly defined as a segment of a major epicardial coronary artery that runs intramurally through the myocardium beneath muscle bridge. This segment of the artery is called tunneled artery or intramyocardial arterial segment. It is dynamic stenosis characterized by systolic compression of the overbridge arterial segment, which disappear during diastole, and it is usually shown on conventional or invasive coronary angiography as milking effect. And as you can see here, this anomaly is mainly located in the left anterior descending coronary artery, which is the main coronary artery that vascularizes the greatest part of myocardium. Myocardial bridging is considered benign anatomic variation, but it has been documented that it may cause myocardial ischemia, such as stable angina, acute coronary syndrome with or without ST segment elevation, then left ventricle systolic dysfunction or life-threatening ventricular arrhythmias, or even sudden cardiac death. Thus, the occurrence of severe cardiac events has raised the awareness of its clinical relevance and the need for appropriate diagnostic tests to identify patients with functionally significant myocardial bridging. What we are doing in our clinic after revealing myocardial bridging on non-invasive CT or invasive coronary angiography, the next step is to perform non-invasive or invasive diagnostics tests to assess the functional severity of this anomaly. And in our institution, the most commonly used non-invasive test is stress echocardiography test because it has a higher sensitivity and specificity for detection of functionally significant coronary lesion in comparison to exercise stress electrocardiography and pharmacological stress echo test, as well as higher specificity in comparison to SPECT perfusion imaging, which means that it has a lower rate of false positive findings. More recently, coronary flow velocity reserve obtained with transthoracic Doppler echocardiography is used in our clinic on daily basis. These two tests are comparable, as exercise stress echo test has a high specificity and positive predictive value for detecting myocardial ischemia, while coronary flow velocity reserve has a high sensitivity and negative predictive value for excluding myocardial ischemia. Although CFR obtained during adenosine-induced maximal hyperemia is the gold standard for the functional assessment of fixed coronary stenosis. It has been shown that this test underestimates the functional severity of myocardial bridging. Therefore, several authors suggest that adequate hemodynamic assessment of this anomaly should include inotropic stimulation with dobutamine due to its dynamic nature that depends on the degree of extravascular coronary compression. Additionally, it has been shown that high doses of dobutamine have the same effect on microcirculation as adenosine, regardless of whether ischemia is present. And the only study that compared CFR during adenosine and dobutamine provocation in patients with myocardial bridging was designed by our cardiology group, and we have shown that CFR during peak dobutamine was significantly lower in stress echo positive in comparison to stress echo negative patients with myocardial bridging, but not during adenosine provocation. This is the first study showing that CFR during inotropic stimulation with high doses of dobutamine provides a more reliable functional significance of myocardial bridging in comparison to adenosine. We actually calculated that the dobutamine test for CFR measurements is about 22 times better for assess the functional significant myocardial bridging in comparison to adenosine 1. Similarly, another study that was also designed by our cardiology group showed that diastolic fractional flow reserve obtained with high doses of dobutamine was the only invasive test that has the ability to identify patients with functionally significant myocardial bridging according to ischemic thresholds less than or equal 0.76. And the optimal cutoff of 0.76 for diastolic FFR during dobutamine provocation has the best sensitivity and specificity, as well as positive and negative predictive value for discriminating the patients with this anomaly associated with stress-induced myocardial ischemia. This cutoff value for diastolic FFR during dobutamine provocation in the functional assessment of myocardial bridging is the same as the cutoff value for diastolic FFR during adenosine in the functional assessment of fixed coronary stenosis, as previously shown in the study by Masayuki Abe and published in Circulation in 2000. These findings implicates that myocardial ischemia is unique phenomenon, but with different pathophysiological mechanism in different pathoanatomical coronary entities, such as fixed stenosis or myocardial bridging. Furthermore, our results confirm previous findings that stress-induced ischemia, as well as CFR and diastolic FFR during dobutamine provocation, correlates well with person diameter stenosis at end diastole, but not end systole, meaning that the decompression of intramyocardial arterial segments is probably slow and incomplete. These findings support the hypothesis that the underlying mechanism of stress-induced ischemia in this patient is probably delay in early diastolic artery relaxation with persistent reduction of vessel luminal diameter in diastole, which may worsen during inotropic stimulation with dobutamine or exercise due to tachycardia or shortening of diastolic perfusion time. In such conditions, severe systolic compression of intramyocardial arterial segment beyond systole into diastole may impair early diastolic hyperemic flow and thereby myocardial perfusion. Also, we have shown that exercise stress echo, as well as both CFR and diastolic FFR during dobutamine provocation, had ischemic values only in patients with stable angina, typical or atypical, whereas in patients with acute coronary syndrome, the results of this test were usually normal. The mechanism of acute coronary syndrome is not fully clarified, but there are several reports that have documented that the vasospasm of intramyocardial arterial segment as a result of impaired endothelium-dependent vasodilatation and at MB site would be the key mechanism. And few studies showed that the presence of myocardial bridging is the independent predictor of acetylcholine-induced vasospasm. And the third possible mechanism of myocardial ischemia in patients with this anomaly is the development of atherosclerotic lesions in the arterial segment proximal to the myocardial bridging, and it is caused by retrograde flow during systole, which leads to the occurrence of low and oscillatory shear stress in the proximal segment of the artery, which then accelerates the development of atherosclerosis. In conclusion, I want to emphasize that there are three possible mechanisms of myocardial ischemia in patients with myocardial bridging. The first one is delayed early diastolic relaxation of intramyocardial arterial segment, which usually occurs in patients with typical or atypical stable angina and documented signs of myocardial ischemia on invasive or non-invasive diagnostic tests. The first line therapy in these patients are beta blockers, which usually combines with dihydropyridine calcium channel blockers. The second mechanism is the development of atherosclerotic lesions in the arterial segment proximal to the myocardial bridging, and it may cause also stable angina or acute coronary syndrome. And these patients need to be treated as any other patient with fixed coronary stenosis according to the current guidelines for stable angina or acute coronary syndrome. And the third mechanism is coronary vasospasm, which leads to the development of acute coronary syndrome. And these patients need to be treated as they have vasospastic angina, but without the usage of long-acting nitrites, because these drugs are contraindicated in these patients, regardless of the predominant mechanism of myocardial ischemia, because this medication may exacerbate pre-existing myocardial ischemia. Also, non-selective beta blockers are contraindicated in these patients who had acute coronary syndrome and who had non-ischemic values or non-invasive or invasive diagnostic tests. There are several exceptions for non-selective beta blockers, which also and alpha blockers such as carvedilol or labetalol, or maybe nebivolol, who is selective beta blocker with vasodilatory effect. Also, the first line therapy in these patients is the combination of non-dihydropyridine and long-acting dihydropyridine calcium channel blockers. And also every patient who had acute coronary syndrome needs to take dual antiplatelet therapy for 12 months according to current guidelines. Thank you very much. Спасибо.
Thank you very much, Serjan. Due to the fact that our speakers are exclusively responsible for timing, we have opportunity to have 13 minutes before the end of the session, and now we will enjoy the Q&A session. So let me start this Q&A session with the first question, which is mainly focused on Professor Giga. Dear Voislav, and this is one of Russian doctors. What adverse reactions can you face in stress echocardiography? Adverse reactions of stress echocardiography. Did you get the question? What adverse events you face with stress echocardiography? Please unmute.
Thank you. Thank you for the questions. We during the stress echocardiography, first of all, it's a pretty safe procedure. The most prevalent adverse event is the occurrence of significant, predominantly non-sustained ventricular tachycardia or atrial fibrillation. According to some reports, the incidence of fatal or non-fatal myocardial infarction or death during the stress echo testing is some kind of 1 on 2,500 tests. But I think that it's a little bit more than it's in real life. And really, I am performing exercise testing for around 20 years, and I really didn't have any fatal event during the exercise testing, with only few myocardial infarctions. Basically, the clinically most frequent are atrial fibrillation or non-sustained ventricular tachycardia.
Thank you very much. Well, and we have a number of questions that were already covered in your previous presentations, but our doctors are very much interested in the question of adverse reactions in interventional diagnosis of coronary arteries. So probably Milan or other or our interventionalists can answer these questions. Please speak up.
Hello, sorry for switching to another computer. I had some technical issues in my laptop, so I will present from Dr. Giga's computer. Regarding adverse effects of functional assessment, there are few of them. First of them is related to the invasive nature of the procedure. You may induce coronary artery dissection using catheters, using wires. We know that these wires, especially earlier generation of these coronary wires, were did not have a very fine mechanical characteristics. They were prone to cause dissection. They could not traverse tortuous part of the vessel. So this is one of the issues. On the other hand, the other set of adverse reactions is related to using pharmacological agent that we use for inducing hyperemia. When we use adenosine, especially intravenously, we may induce some hemodynamic changes like pressure drop or flushing or chest pain or something like that, or transient AV block sometimes. But when you stop this medication, it usually resolves within seconds, so it is not a very big issue. When we use papaverine for inducing hyperemia, we sometimes have another kind of adverse reaction, because papaverine, when mixed with contrast, can cause some precipitation, and if we mix these substances and give them intracoronary, it may sometimes cause some ventricular arrhythmias like torsades or something like that. But we do not often use papaverine. We usually use adenosine, or sometimes its analogs to induce hyperemia. When we use non-hyperemic indices, we do not have this kind of problems. So this will be, in general, major adverse reactions of this procedure.
Thank you very much.
Thank you.
Dear experts, another question to Milorad. And the question is about preferences. What would be your preference, whether you prefer medical load, the use of medical approaches, pharmaceutical approaches in stress cardiography, or physical activity, physical exercise? So what are the preferences? When and how you select stress factor in echocardiography? When pharma, when physical? Please speak up, unmute.
Yeah, well, thank you for the question. Well, in our lab, we mostly use exercise for testing stress echocardiography, but in case that patients cannot walk, for example, some Leriche syndrome or some other issues. For example, if we want to, for example, examine significance of aortic stenosis, we use pharmaceutical medication for as a stressor. But it was shown that the best, for example, hemodynamics examination, especially, for example, for a hypertrophic cardiomyopathy, examination of left ventricular outflow tract gradient. So if you have a latent left ventricular outflow tract gradient, the best thing is to do exercise, because it mimics everyday situation of the patients. So you're standing and you're running, and that's the best stressor, and better than medication. So definitely in our stress echo lab, we are using as much as possible regular exercise test together with echocardiography, so stress echocardiography test, as on a treadmill. And for CFR, evaluation of CFR, we are most of the time, 99%, we are using adenosine. So, but that's a different thing. If you ask for a stress echocardiography test, we are using a treadmill test. And just in cases when you have contraindications, you use dobutamine. If you agree, Voya is chief and leading our stress echocardiography.
Thank you very much, colleagues. So with that, we depleted our question and we covered multiple issues. So we would like to thank our distinguished colleagues. This is really very complex, very interesting, and very organic symposium. This presentation added to each other. So this is the best practice from Serbia, from Belgrade, where our colleagues using non-invasive methods offered how we can use different parameters for assessment of coronary flow to specify risk of coronary events, and plus to that in interventional methods and tools that also allow us to improve the diagnosis and to identify the prognosis and the outcomes for our patients. So we are very grateful to our Serbian colleagues. So with that, we finish this symposium and we deserve some break. And after that, we can enjoy our next session on the issues of osteoporosis. And this symposium will start in this hall, St. Petersburg, at 4 p.m. Moscow time. So thank you very much. Enjoy your break. Have a good day and goodbye. So hope seeing you colleagues later on. Many thanks to those who are with us online, who were with us in St. Petersburg hall in our broadcasts. Hope seeing you later. Have a good day and goodbye. Enjoy your break.
1, 2, 3, 4, 5. Раз, два. 1, 2, 3. Эй. Эй, 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 эй. 1, 2, 3, 4, 5, 6, 6, 7. 1, 2, 3, 4, 5, 6, 7. Раз, два, три, четыре, пять, эй, 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 эй. Раз, два, три, четыре, пять, шесть, семь. 1, 2, 3. Раз, два, три, четыре, пять, шесть, семь. 1, 2. Раз, два, три, четыре, пять. 1, 2, 3, 4, 5, 6, 7. Раз, два, три, четыре, пять, шесть, семь. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Эй. 1, 2, 3, 4, 5, 6, 7. Раз, два, три, четыре, пять, шесть, семь. 1, 2, 3. Раз, два, три, четыре, пять, шесть, семь. 1, 2, 3, 4, 5, 6, 7. 7. 7. 7, 7, 7. Раз, два, три, четыре, пять, шесть, 7. 1, 2, 3, 4. Раз, два, 3. 1, 2. Раз, два, три, четыре, пять, шесть, 7. 7. Раз, два, три, четыре, пять. 1, 2, 3, 4, 5, 6, 7. Раз, два. 1, 2. Раз, два, три, четыре, пять, шесть, 7. 1, 2, 3. Раз, два, три, четыре, пять, шесть, 7. Эй, эй. Чё себе? Раз, два, три, четыре, пять. Уважаемые коллеги, те, кто только что подключился, я снова вас приветствую в зале Санкт-Петербург.
Those who joined us, we are welcoming you from St. Petersburg Hall, and we're making the broadcast from here, and we are going to discuss one of the interesting challenges. I would believe that this is a medical and social challenge of the healthcare. This is a problem of osteoporosis, which is related not only to the quality of life, but also guiding the outcomes of our patients. And with my greatest pleasure, I'm happy to give the floor in this symposium, which is called Osteoporosis from Theory to Practice, to the first speaker who already took multiple presentations in the 10th online congress, and this is Dr. Manusha Grigory Aramovich, who is endocrinologist, dietologist, and clinical psychologist, and the lead of therapy department MedC Moscow. And the topic of his presentation is osteoporosis, the fracture that is avoidable. Avoidable fracture. Grigory, can you hear me? Yes, absolutely. Good afternoon. Happy to hear and see you again. I'm so happy that we are discussing such important topic like osteoporosis, because doctors, therapists, and we have mainly therapeutical congress, although I know that many other specialties are also involved, we are frequently facing this challenge. And sometimes basic knowledge is not sufficient enough. So in order to fill the gaps in knowledge, in the experience in terms of osteoporosis and modern methods of osteoporosis treatment. This is exactly what we are going to discuss today, together with Dr. Baranova, who is the global expert in osteoporosis treatment, and she will cover the practical part on how we are treating osteoporosis with example, and I will cover the theoretical part, which is also important, and that's why we will start from theory. So, colleagues, our topic is osteoporosis, avoidable fracture, and we would like to have a chance to avoid it. Let's start from the osteoporosis. This is metabolic disease of the skeleton, reducing bone mass, changed microarchitectonics of the bone tissue, and as a result, fractures with minimal low energy trauma. We are online, but nevertheless, each of us can try to answer these questions. Whether you agree or disagree with this data of incidence and prevalence, we know that in Russia, at the age of 50 plus, osteoporosis is seen in 34% of females and 27% of males. And previous stage osteopenia could be seen in 33 and 44% correspondingly, males and females. Now my question to you, what do you think? How many patients in Russia suffer from osteoporosis? So we have a couple of seconds to answer, and you will see this figure. It's about 14 million of patients with osteoporosis, and about 20 million those who have bone mass reduction. And what about the year? How do you think osteoporotic fractures we have annually world globally? Why is it so important, and why this figure is really very big? And you know it from the following line, because the mortality rate within the first year after the fracture is from 12 to 40%. We are afraid 12 to 40%, that's really a crazy figure, and that's about 40%, that is mortality rate. Unfortunately, our attitude to osteoporosis is not always attentive. So we're not so attentive, but every minute we have 17 fractures in Russia of peripheral skeleton and 7 vertebral fractures, and all of them are preventable. Also, we have differences in gender distribution, males versus females. Hospital mortality after femoral fracture is twice higher in males, but mortality is very high, and total mortality first year after the fracture is up to 50%. And in females, it's an average 20-25%. So please pay attention. Not only postmenopausal women, please pay attention to the postmenopausal men. So this is not the very fresh data. This is just 2012, but you see that almost 500,000 fractures, osteoporosis versus the data of strokes and infarctions. We will start from diagnosis. So we have several options to diagnose osteoporosis. First, we do the screening to see the risk groups with a high rate and high probability of fractures. And then we use FRAX algorithm, and I will show you it on my next slide. If you haven't used FRAX yet, That's really very useful tool that can be used just during the appointment. It takes a couple of minutes and we get very first data even if we don't have densitometry. This screening is recommended for all women 50 plus. FRAX is still absolutely risk of fracture. So here you see the link how to find this electronic calculator. Actually, you can print FRAX in the internet, and then it's important to change the country because for each country there would be special criteria. So you can find it in the menu selection. So there would be several questions. I'm not going to discuss all of them or to show you how we calculate these risks, but there will be several questions there. And among them, for example, if you have diabetic patients, let's say type 2 diabetes definitely, because about type 1 there is a special calculator. So you can use rheumatoid arthritis coefficient if patient has diabetes in the medical history, because patients with diabetes may not have correct representation of the data. And the golden standard of our diagnosis, this is still densitometry. X-ray densitometry. Why yet? Because new methods are coming that are also interesting for the diagnosis of osteoporosis. Densitometry is a very simple non-invasive method. It takes again about 10-15 minutes, and majority of the doctors can interpret the results on their own, because what is less than minus 2.5 by the Z score is already osteoporosis. So normally we take average in the lumbar spine, and then we make a conclusion whether the patient has or has not osteoporosis. And the same for femoral neck. So there is index neck, which is indicating the anatomical location, and then we look at osteopenia and osteoporosis, and there is a whole hip, which is also important when we assess efficacy of our treatment. So who and when should get densitometry? So these are international guidelines on that. So these are all females aged 65 and older. And if you see a patient 65 plus, just ask her a question. Have you ever performed densitometry? I'm just asking differently. Have you ever heard the word densitometry? And if the patient looks puzzled without understanding what it means, that means this test has never been done. Because if at least this test was done, then possibly patients remember the name of the test and we can believe that it has been done. So postmenopausal women before after 65 and all males 70 plus. But also there are other parameters shown here on the screen where we can assess the need of densitometry. So this is new method which came very recently. This is so-called REMS, radio frequency echography mass spectrometry. So what are the pluses? So this is not X-ray. This is not X-ray because we have methods to assess osteoporosis using ultrasound. This is just the bone, residual bone, but unfortunately this is not quite informative, so I do not recommend this ultrasound-based study, and also not the golden standard is CT densitometry, but X-ray densitometry. This is exactly what we are based upon. So if we compare, so there was comparative study of REMS, radio frequency echographic mass spectrometry, with the golden standard, and actually they're very close. They are very close. So we can talk with time, possibly REMS will become new golden standard as well. Why? Because first of all, this is not invasive. This is very fast. Then the station is very mobile and portable, so minimal size equipment, and it can be even at the patient bed. It can be even there. Also, no need of special certification, so there is no need to be X-ray specialist or radiologist in order to interpret densitometry. So you just got a training, and then you can easily work with this machine during your appointments. Well, yet this is low prevalence and high price. There are just several machines in Russia. And yet we do not have full-fledged data that can recommend us this machine as the golden standard, just like densitometry. But actually, this is our future. If we conclude from the clinical guidelines on osteoporosis published in 2020 and a draft shown here, actually nothing changed. So how do we make diagnosis of osteoporosis? First, this is low energy of fracture of large bones in the medical history. If you ask whether there were any fractures in the medical history, compression, spine, or large bones, trabecular long bones, then it should be very concerning, and we can immediately make this diagnosis if there were some fractures. Then high-risk were fractures without density, and then densitometry data that confirms that patients does have osteoporosis, and then we make the diagnosis and we start treatment. Well, there are some lab tests that can also be used. So the guidelines for laboratory diagnosis has changed in the draft of guidelines. So these are basic parameters that we can check to assess predispositions to the development of osteoporosis. You can enjoy it on the slide. And also we remember that osteoporosis cannot be made just on the lab test. This is just the additional method which help us to differentiate the other diagnosis. And on the other hand, we can understand what to do next with this patient. What drugs are available in Russia? We have anti-resorptive treatment, and these are bisphosphonates plus denosumab, Prolia. This is Runkle monoclonal antibody. Then strontium granulate with unknown mode of action, and anabolic treatment, and there is only one, teriparatide, which is parrot hormone PTH analog. Speaking about strontium granulate, we're almost not using it because this is high-risk cardiovascular complications, thrombosis, thromboembolis, and we remember that patients are elderly and they already have very high risks related to the cardiovascular complications. So why to enhance these risks by our drugs, by our treatments? So this is not logical. So for the routine treatment, we are not using it. In order to understand what are osteoblasts and osteoclasts, I will show you a very simple picture. Our bone is continuously updating. Osteoblasts create new bone, osteoclasts destroy the old one. So it's like old asphalt which is removed and new asphalt on top. So this is remodeling. But unfortunately, in menopausal females, especially with reduction of sex hormones, we observe reduced number of osteoblasts restoring bone, but osteoclasts are still there. And this is how we observe just the destruction of the bone, and then osteoporosis is developed. This is, in a simple words, explanation. There is a proper mode of action. Actually, you see everything what we can use for the treatment of osteoporosis. So on the left, osteoblasts creating new bone tissue, osteoclasts on the right, they are destroying the old one. Bisphosphonates are acting on the osteoclasts, and they suppress activity of activated osteoclasts. Teriparatide is affecting osteoblasts. But denosumab, that's exactly what we are going to talk about. It inactivates osteoclasts and also facilitates restoration of bone tissue. So there is unique mode of action because not all the drugs, including bisphosphonates, may affect cortical tissue. So that means when we speak about the spine treatment and femoral neck treatment and osteoporosis in both locations, then we should prefer Prolia because it will influence both locations. What are the recommendations for treatment? So this is Russian National Association of Endocrinologists. So indications to denosumab, Prolia is the following: postmenopausal osteoporosis, male osteoporosis, glucocorticoid-associated osteoporosis, treatment by aromatase inhibitors because of breast cancer with no bone metastasis, prostate cancer with hormone deprivation treatment, patients with dramatic loss of BMD in the femoral and radial bones, mineral bone density, compromised renal function, so it's better to use Prolia. And if there is inefficacy of bisphosphonates, so if we treated patient for some time with bisphosphonates, then we get the effect, and then there is no dynamics. So we check densitometry in 1 year, in 2 years, but still there is no positive dynamics. So in this case, we can also use Prolia. So how long we can use it? For 10 years. Teriparatide has limitation up to 2 years, and also these drugs can be used simultaneously, and probably that would be the most effective treatment by now. But there is a nuance. As soon as we stop Prolia, we never stop treatment, and we don't let patient go, because in that case we can face a relapse and very fast return to the baseline level, because for many years of treatment we got benefits and we can lose these benefits. It's just because of mode of action. It's very effective, but in order to fix the effect, we minimum for 1 year, maybe for longer, sometimes for 2, sometimes for 3 years, we still administer bisphosphonates as maintenance. They can be used up to 5 years in tablets or up to 3 years injectable. So how long can we continue Prolia? So if patient has no fractures and we use T criteria less or equal -2, that means osteopenia in the femoral neck or in the lumbar spine. And at that, we switch patient to bisphosphonate for 1 or 2 years, we fix the result, and then we can discuss with the patient so-called drug holiday. So the time when we simply follow up the patients and we use vitamin D, we can check annually densitometry, and we assess the need of restart of treatment, re-challenge. But if we see that the patient had vertebral fractures or multiple fractures in the medical history, definitely not car accidents, less traumatic, less energy, low energy compression, then this treatment can be up to 10 years, no matter what figures we reach on on Z score, T criteria by Z score. If we compare bisphosphonates with Prolia, so in that case, we can speak about the selection of Prolia as a first line of treatment. I repeat it, but in this case, this is very important. This is really important that cortical bone damage is a priority for us. And in this case, we should administer specifically Prolia with all similar parameters, because we can use it with the lumbar spine, but for femoral neck, it is a priority, as well as if there is limitation for GFR, no limits for Prolia, but there are limitations for bisphosphonates. Bisphosphonates mainly tablets or injectables, IV. And definitely, the administration of tablets is associated with the problems with GI tract in elderly patients. Well, elderly patients, they do have problems with CKD, definitely, and multiple other problems with GI. That's why sometimes tablets associated with the worsening of the baseline GI disease, and not all patients accepted that. So we can use parenteral or sub-Q. Sub-Q, why sub-Q is important? Because naturally, there is high efficacy in long-term treatment, and also we try to avoid adverse events. If we speak about injectables, bisphosphonates, then this is monthly. Ibandronic acid once in 3 months, ozolidronic acid once a year, which is very convenient, by the way. Unfortunately, injections by themselves associated with a flu-like effect with adverse reaction after the injection itself. Here, the plus is that number of patients, from my personal experience, all the patients who are administered Prolia for the first time during the administration, I show them how to inject. It's absolutely not difficult. So normally this is abdominal injection, sub-Q injection, very simple. So if this is a patient with insulin treatment or patient is getting GLP-1 receptor agonist, it's not a problem for them. So they normally do it. It can be abdominal part or thigh. So why sub-Q is very good? Now we frequently speak about the pandemics of COVID-19. And all these 3 days of our conference, definitely COVID topic was always discussed actively. So when we were limited in the hospital access in spring, for example, those patients who had to do infusion or IV injection, unfortunately could not do it because the majority of outpatients were closed and majority of hospitals were reallocated to the COVID dedicated sites. And in this context, to make next infusion was quite challenging for the standard patients. Those patients who were trained by sub-Q injection, they could simply do it without missing the dose, which is extremely convenient. Let's appreciate guidelines of Endocrine Society, and this is probably most respected associations among endocrinologists in the world. This is American Association. So let's appreciate their guidelines. So when to start osteoporotic treatment, they have different approach. They say that we have to grade risks. So there is low, moderate, high, or very high risk. And depending on the type of risk, we select the proper treatment in the chart when we can administer denosumab. So here mainly patients with a high or very high risk that are indicated for denosumab, or let's say in efficacy of bisphosphonates. So we can use it as a first line, and then, if needed, we can prolong the treatment with bisphosphonates as a maintenance. Fracture risk assessment should be done not less than 5 years after the start of treatment. And for the patients with a high risk group, they should continue denosumab or start alternative treatment. So what is the influence to the frequency of fractures? So why do we start treating osteoporosis? Not just to get nice figures next year on the cytometry. All that is done to reduce the fracture risks and fracture rate. And in this context, Prolia already proved how effective it is. So this is a reduction of non-vertebral fractures by 20%, then reduction of proximal femoral fractures. This is what we are afraid of, which is very disabling. This is really with high mortality. It can reduce by 40%, and the reduction of vertebral fractures de novo by 68%. What else do we remember when we talk about osteoporosis? This is famous vitamin D and calcium. Let's talk about it. Calcium and vitamin D. Well, the same guidelines in females in postmenopausal period with low bone mineral density, with high risk of fractures. We are offering definitely calcium in combination with vitamin D as add-on to main treatment. We never ever administer calcium or vitamin D instead of main osteoporosis treatment. I would like to draw your attention that our colleagues, traumatologists, after the fractures, they simply administer calcium, just calcium, believing that that is it. And they never limit calcium intake, and sometimes we see negative effects of such administrations because patients have renal stones, bladder stones, because they are taking calcium for a long time uncontrollably. But what they need is actually full-fledged treatment of osteoporosis. So what does it mean, enough calcium? Not all of our patients are getting enough calcium because we need to take at least 3 meals of dairy products a day. So that is 150 grams of yogurt, and I don't think that we can take it 600 milliliters of milk, 300 grams of cheese. Well, definitely you may not necessarily get it from meals. Majority of our patients definitely cannot eat so much calcium. That is why we administer additionally tableted calcium. Next, the influence to the fractures. Well, calcium and vitamin D doesn't influence that. So what is the normal or optimal level of vitamin D? Is shown here on the slide. This is from 30 to 90 nanogram per milliliter. This is Russian clinical guidelines on vitamin D deficiency. The optimal level is 30 to 60, 40 to 60. So normally higher than 40. So these are recent guidelines of vitamin D deficiency in adult patients, and actually nothing changed here in terms of guidelines. We are still administering 14 drops of cholecalciferol daily for 1 month in insufficiency and for 2 months in deficiency. Lower level. Single dose of more than 60,000 international units per week, or more than 30,000 per month, was associated with a high risk of falls and increased fracture rate. So we have high doses, 100,000, 300,000 in ampoules. So they do the injections. No, that's not very good. We need more homogeneous saturation of vitamin D. And the last question, can I take not the pharmaceutical drug, but bioactive additive? And there is a site which is called LabDor. This is independent laboratory which is accredited
by FDA, and believe me, it's very difficult to get accreditation of FDA. So they're checking all biological additives that are sold in the American market. So this is a very famous website where our patients are purchasing biological additives. So among vitamin D, they analyzed 19 products and only 9 of them were certified. And there are multiple challenges, both in doses, because sometimes it's one dose, but in reality it's either smaller or bigger, and also with the quality and with the safety. Because in some drugs they found heavy metals and sometimes lead in one of them. But with calcium, it's much poorer because from 30, none of them were certified. And important issue here, so our colleagues, dental doctors, asking about implantation, what about jaw necrosis when we provide bisphosphonates treatment, and Prolia and teriparatide. So let me introduce you two meta-analyses about that. So the first one is the systematic review, which was comparing the safety of denosumab with bisphosphonates. And this is very clear that everything was quite fine in comparing with bisphosphonates. And last line here, there was no statistically significant difference in hypocalcemia, atypical fractures, and jaw osteonecrosis. And that's another analysis of 2019, which showed that the prevalence of jaw necrosis, jaw osteonecrosis, was actually very low, and there is no true information about denosumab-associated osteonecrosis of jaw. That is why, with high probability, there will be no problems. But if we want to give practical advice, so it is recommended to perform implantation of teeth 3-4 months after the injection to minimize the effect of the drug, and that would be the most convenient implantation time. Well, how to make the selection? That's very important. We always can choose, and that's very good, because in the market there are multiple options, and we can select the one which is most convenient for our patients and the best indicated. How Prolia can influence our patients with osteoporosis? This is very effective. This is sustainable and increase of BMD that is playing for about 10 years. This is high compliance of the patients because injections just twice a year, no tablets daily, no tablets monthly, no tablets weekly, no need of IV. And patients very frequently do it. And again, safety. We can use it both with compromised kidney function. We have very low rate of adverse events. And from the beginning, when I started using it, just for many years, I remember only one case of adverse reactions that was associated with the flu-like syndrome. So this is the approach that requires multidisciplinary approach, traumatologists, GPs, rheumatologists, endocrinologists, gynecologists should be included into the prevention with risk assessment of the fractures and referral to the doctors. So most frequently, this endocrinologist or rheumatologist that would continue treating these patients and reduce his or her risks. Thank you very much for your attention. And if you have any questions, I would be happy to answer. And now I'm happy to give the floor to Irina for practical part of our session. Thank you very much. Thank you very much for your presentation. Yes, very comprehensive presentation, quite systemic representation of the issue, of this challenge. And yes, truly, let me give the floor to Irina Baranova, who is the professor of hospital chair, Pirogov State University, and also she's a doctor of medical science, professor, and one of the co-authors of the clinical guidelines on osteoporosis. And the topic of the presentation is probably for the treatment of for different forms of osteoporosis. Dear colleagues, today I would like to look at cases of different patients. they have the same problem. They suffer from different forms of osteoporosis. Let's start from the first patient, age 55, menopause from the age of 50, from chronic diseases, arterial hypertension, grade 1, no hazardous habits, with osteodensitometry. There are low levels meeting osteoporosis in the left femoral. So she didn't have low energy fractures, but there is a problematic medical history. In her mother was a femoral neck fracture, and she couldn't tolerate the surgery. And her daughter doesn't want to repeat the story, and she's referring for the consultation. So she has having diagnosis of postmenopausal osteoporosis. And this is what Grigory was talking about before. We calculated FRAX here. You see, we introduced female gender, weight and growth, then family history. Then we have T criteria here, minus 2.8, and also we calculated the risks of mean osteoporotic fractures and femoral fractures. That's pretty high. That means patients has pretty high risk of fractures. If we take the chart that calculates the threshold level, and if we compare the risks of main osteoporotic treatments, which is 21 with patient's age 55, so then it appears to be that the patient is in the red zone. Definitely, she should be treated, and she's in the risk group for the development of osteoporotic fractures. And this is the data that Grigory already showed before. So what denosumab is showing, Prolia, in the study on postmenopausal osteoporosis, it has been shown that Prolia reduces it reduces the fractures in the pieces rich with trabecular tissue. So by 68%, we reduce the risk of vertebral fractures, 40% femoral fractures, and by 20% risk of other periphery fractures. And in the extended phase, freedom, it has been shown that that effect that provided denosumab with a reduction risk of fractures in 3 years actually was supported for the use of Prolia for about 10 years. So here on the left, you see the reduction of fracture risk for about 10 years, and on the right, non-vertebral fractures. So this is not hypertension stage 3, but also diabetes with diabetic nephropathy, retinopathy, neuropathy. So creatinine of blood 150 micromole per liter, and estimated GFR is 31 milliliter per minute. In densitometry, we see the low mineral bone density, which means osteoporosis both in the lumbar spine and also in the left femoral neck. And also quite recently, she was having shoulder fracture in the typical location. So can we administer Prolia by now? Yes, we can, because treatment of this drug is not related with the development of complications. Also, in the FREEDOM study, the consequences of fracture more frequently seen in the patients that were getting placebo versus patients that were getting the other options. Another objective thing, this is chronic kidney disease and anti-osteoporotic treatment. Well, we are most frequently used not the GFR, but estimated creatinine clearance, but Cockcroft Gold. If it's less than 35 milliliters per minute, so this is contraindication for the administration of the administration of the bisphosphonates lower than 30 milliliters per meter. This is contraindication for teriparatide. Our patient has very low estimated creatinine clearance, but still we can administer denosumab prolia to her because the metabolic and excretion does not depend on the renal function. In the label on prolia, in 55 patients with different severity of renal dysfunction, including patients getting dialysis treatment, it was shown that the severity of renal failure did not influence the pharmacokinetics of denosumab. And let me show you the data that was published upon the results of when the patients were split in the groups according to the stage of CKD. And it appeared to be that both in the preserved renal function, prolia provided very good effect on the increase of the mineral bone density in the lumbar spine, specifically in the hip parameters in patients with the second, third, and the fourth stage of CKD. Moreover, in the same study, it was shown that denosumab reducing the risks of vertebral fractures at any stage of chronic kidney disease, and it was not related to the increase of side effects in patients with kidney failure. Another story. This is a patient, age 76, complaining of back pain, with a long smoking history of about 20 cigarettes a day, with a diagnosis COPD, chronic obstructive pulmonary disease, and inhaled steroids are administered and long-acting beta agonists. So there were 2 exacerbations of COPD in the previous year. So that means patient is highly symptomatic, and this is severe COPD, group D. So the results of examination in densitometry, we see reduced bone mineral density in all the compartments, and in the lab test, you can appreciate severe deficiency of vitamin D, increased markers of resorption, and the reduction of the level of osteocalcin. So the same study in the measurement of bone mineral density, patient X-ray morphometry. So all densitometers now have the software to assess the vertebrae for the diagnosis of the fractures. That is why when you administer densitometry, I recommend you to do it simultaneously with X-ray morphometry of the spine. And as you can appreciate here, they identify severe fractures of 11th thoracic, 2nd lumbar, and moderate first lumbar as well. So what should be the next tactics? Well, the patient also definitely needs treatment. And in this case, the patient was administered prolia. But why? Because actually the study was carried out. This is a DAMA study in males, where it has been shown that regardless on patients' characteristics by the moment of inclusion into trial, in males, depending on the age, on the location, geographic region, on the presence of fractures in the medical history of tobacco, smoking, etc., versus placebo. Treatment with denosumab led to the severe assessment points. This is the lumbar spine and the proximal femoral and distal. Another patient, she's 78. She is suffering from hypertension, ischemic heart disease, and she has also rheumatoid arthritis, seronegative, and she's getting the treatment on methotrexate. several risk factors for osteoporosis: age 78, low index of BMI, and rheumatoid arthritis. 1995, shoulder fracture. Although the doctor that was consulting her because of osteoporosis didn't take that into consideration and did not administer any treatments, but it had to be done back in 1995. Then in 2013, she had densitometry, and here you can appreciate T criteria in the lumbar spine and the femoral neck. This is osteopenia, and again, she is not administered treatment, regardless the fact that she had already had low energy fracture in her medical history. Now in 2015, she's coming back to densitometry. She's followed, and again, the lumbar spine Z score is reducing and femoral neck Z score reducing. And finally, the doctor who is doing the diagnosis and the treatment administers her peros bisphosphonates. But regardless, the administration of peros bisphosphonates, still in 2016, we observe the shoulder fracture, and in 2017, it's a catastrophe. This is L4 and 5 fractures. Patient had surgery, and now it becomes clear that that treatment that she was administered is not effective anymore. So how the patient was taking peros bisphosphonates, we don't know. We don't know. Although she's telling us that she was taking regularly. But you see that compliance to Prolia is higher versus compliance to bisphosphonate, 62 versus 30. But the treatment is not effective, and definitely here we mean the change of drug treatment. Denosumab appeared to be more effective in non-treated patients versus alendronate, and besides, there were few comparative trials when the patients with the bisphosphonate treatment, peros bisphosphonates, were switched either to Prolia or main peros bisphosphonates, ibandronate or isandronate, and then there was comparison with much stronger bisphosphonates, IV, with zoledronic acid. So this is dynamics of mineral bone density after the switch patients from peros bisphosphonates to zoledronic acid or Prolia. And Prolia demonstrates much better effect about the growth of mineral bone density in the lumbar spine and also in the proximal femoral and also in the distal shoulder. So denosumab was administered, which patient is taking regularly from 2017. And here you see positive dynamics of bone mineral density. Unfortunately, this year, because of coronavirus infection, we could not provide retest of bone mineral density, but I think possibly it's not quite urgent because the patient currently in the category of high risk of secondary fractures and severe osteoporosis, and she should take denosumab very long time. Another patient, aged 58. Patient is complaining on the thoracic pain, so used to be a minor, also with the diagnosis of chronic obstructive pulmonary disease. And in the 2015-2016 was getting perosprednisone 5 milligram. 2016 received consultation by pulmonologists, and the treatment by steroids has not been stopped. So they administered inhaled steroids and long-acting beta-2 agonists. But the patient, although there was no medical guidelines, continues using monthly IV steroids. And this is the data of the examination. You see pretty low bone mineral density And this is the data of X-ray morphometry, which was done simultaneously. And it is very clear that the pain in the thoracic and in the lumbar spine is due to the multiple fractures. These are not just the fractures of the lower thoracic and lumbar spine, but these are also high about T5, T6. So normally we see them very rarely, these high rate fractures, but in patients with steroid-associated porosis, we see them pretty frequently. Specificity of glucocorticoid osteoporosis, the loss of bone marrow happens very fast. And at the same time, the risk of fractures is really increased. So they have different localization, but as it is shown here, with this clinical example, so there are more frequent fractures of bodies, of vertebrae, and in 2/3 of cases, they are absolutely asymptomatic. And yeah, they are just accident findings. So the higher is the cumulative dose and duration of treatment in steroid song, then the higher the risk of fracture. And right now, it is clearly shown that here there is no safe dose of Peros steroids, absolutely. These doses of prednisone, 2.5 milligram per day, increases the risks of lumbar fractures. And in the dose, 2.5, 7.5 milligrams, so the risk is even higher. The other specificity of glucocorticoid osteoporosis is the development of fractures. It does not depend on mineral density of bone marrow, and it can happen is a very high level of bone mineral density versus postmenopausal. So in postmenopausal females, males 50 plus, that are just having or just planning long-term treatment by steroids is different from the concept that we used to have for the primary osteoporosis. At the age of 70 plus, low energy fractures in the medical history, high daily doses, and now it's 7.5 milligram. And this is not lower than -2.5 standard deviation, and this is a level that we normally use in male 50 plus and in postmenopausal women, but -1.5 standard deviations or lower. And 10 years risks of main osteoporotic fractures by FRAX that is higher than threshold of intervention. But here we need to make the correction to the main risk of main osteoporotic fractures, that is calculating FRAX. And if the dose is 7.5 milligram or higher, then we multiply this risk calculated by FRAX in 1.5 for main osteoporotic fracture and in 1.2 for the hip fracture. So the efficacy of denosumab Prolia was proved in the comparative study with risendronate, which many years ago already proved its efficacy in the treatment of glucocorticoid osteoporosis, not on the treatment, but also in the prevention of the development. So patients were split into two groups that continued long-term treatment by steroids or just started long-term treatment of steroids. And here you can appreciate that the daily average dose and the duration of treatment in that group that continued the steroid treatment was really very long. Also, let me pay your attention to the following, that they were patients with very different diseases. So the main group here are definitely the patients with connective tissue, rheumatoid arthritis, etc., etc. And except steroids, they were also taking non-biological immunosuppressants or steroids and biological drugs. So it appeared to be, so when we compared Prolia with risindronate, as you can see here, the mineral density of in both groups of those who continued treatment by steroids and also the ones who just started long-term treatment by steroids. So in both groups, Prolia provided more severe increase of bone mineral density in the lumbar spine in all assessment points, starting from the first one, 6 months after the start of treatment. So, and that's the percentage of measuring of bone marrow proximal hip. So also significant effects from denosumab versus risindronate in all the points of assessment in 12 and 24 months. Well, definitely, there is a question, as in the study on postmenopausal osteoporosis, it has been demonstrated a little bit of increase level of infection, whether treatment of denosumab can increase risk of infections in such severe category of patients. For example, those who are taking steroids. So that means in patients of high risk. So this question is still relevant in pandemia, in coronavirus pandemia. But there were quite a lot of studies carried out that showed that denosumab does not increase the risk of infection in the patients with a high risk of infection. So that means these are the patients who are taking different biological drugs, including infliximab and palbociclib. So patients who are taking steroids in high doses, so these are patients who, beside steroids, also using non-biological immunosuppressants like methotrexate and azathioprine. And finally, the ones who are taking steroids in high doses and biological drugs as well. Safety of denosumab was also shown in patients with oncological diseases, those who are getting chemotherapy. The discontinuation of Prolia, and Grigori already was talking about that. So this is quite reversible. So discontinuation leads to the reduction of bone mineral density or the increased resorption markers. But changes shown after the end of denosumab is the significance of reversibility of this effect of unnatural cause of osteoporosis. Osteoporosis is a chronic disease. As well as we are treating the same arterial hypertension now, probably no one would imagine that that we need to stop the treatment. Also, osteoporosis should be treated continuously. Yes, we can take some short drug holidays, but mainly we mean here the drug holidays in case of bisphosphonates, because bisphosphonates are really accumulating very effectively in the bone marrow. That's why we can make short of break, but at the same time, you should not let the patient go for a long time. But the patient should be followed, should be properly followed, and possibly in 1 year or in 2 years, the treatment is about to be continued. So what to do if you decided that treatment of denosumab can be continued or can be stopped? So for that, we need to look at the risks. So for this or that patient, if this is a high risk of fractures, so there is medical history of the fracture, multiple periphery or then other fractures, then the optimal is to continue the denosumab treatment up to 10 years. And within this period, as it has been shown before, on using effective and safe treatments. So speaking about patients with moderate risk of fractures, for example, low mineral. So if this is 6 months, then the treatment should be stopped and continued for about 3 years, and then if we change mineral bone density, or if we reach the targets, if we increase mineral density of bone marrow by t-score, but -2 standard deviations or higher, with the absence of low energy fractures in time during the denosumab treatment. So as soon as we decided to stop denosumab, and Grigory said about that before, in order to stabilize the effect, at least for 1 year, we need to administer bisphosphonates. For perose bisphosphonates, that is in 6 months after the last injection of denosumab. So when the drug stops its action and you administer alendronic acid with a duration of about 1 year. Speaking about zoledronic acid, so here we need longer periods, and the experts, Russian experts for osteoporosis, that we need additional break for about 65 days. But normally they say the following: after the last injection of the denosumab, it should be about 9 months. And it should be IV zoledronic acid. So that means, and after that, the treatment can be temporarily discontinued, but don't let them go for a long drug holiday. So I'm showing you main indications for Prolia. So this is postmenopausal osteoporosis and the loss of bone mass in females getting treatment by inhibitors of aromatase in breast cancer. Also, this is osteoporosis in males in the high risk of and in men with prostate cancer who are getting hormonal deprivation treatments, and relatively new indication, which is a loss of bone mass related to the long-term treatment by systemic steroids in adult patients and increased risk of fractures. So different patients, they have the same problem. They're suffering from osteoporosis of different severity, and there are common solutions. You can administer denosumab Prolia, the drug, which is sub-Q, once in 6 months. Thank you very much. I wish you all the best. Thank you very much, Irina. So that's really a very interesting presentation where you managed to merge, due to your experience, clinical practice, clinical cases, and theory merged into one. So this mutual penetration of both is very impressive. So thank you very much for that. And that was Irina Baranova, who is the professor of pediatric chair of medical Pirogov Institution. And we received many questions now to our distinguished experts, to Grigory and to Irina. The questions are mainly about, not about the osteoporosis, but also these questions associated to osteoporosis. So let me ask the first question to Grigory. Grigory, our colleagues are very much concerned about the clinical trials of biologically active additives on calcium and on safety. Well, that's a very good question. Thank you very much for that. Well, thank you very much, dear colleagues. Well, as far as I know, there were no studies, full-fledged studies at the levels what I said before, for the United States, etc. It was not carried out because except because regulators that make decisions actually did not carry out, and we do not assess doses in these additives. We don't assess impurities. So these are not pharmaceutical drugs, because majority of additives, these are additives that we are purchasing with American websites. So you can easily find that majority of additives, vitamin D and calcium and to see whether they meet the criteria of efficacy and safety. I never heard that there was something similar carried out in Russia. Can I add on? Yes, frankly speaking, the situation is not quite clear to me. When the patients are ordering different additives on the American websites, because in Russia, I believe, we have enough, because if we speak about osteoporosis, so we have very good calcium additives, vitamin D, and well, this is not clear. This is not clear, this desire of our patients to buy something abroad. Because mainly they bring everything which is already available in the Russian Federation. Thank you very much. So continuation. Another question to Grigory. What about prioritization about the fat and water-soluble vitamin D? Well, that's two great forms, fat-soluble and water-soluble. Cholecalciferol is not actually available, and actually, so they announced that vitamin D is helping with COVID-19. Well, hopefully it will come back. Well, at least Merck is not discussing what is going on with fat soluble, but the efficacy is comparable. So sometimes there is odor, some positive to that. So this is the issue of whether like or don't like, but actually they're comparable. So we believe that the water form is absorbed a bit better. And nevertheless, in terms of efficacy, long-term efficacy, if you look at the saturation by vitamin D by the test, it's quite comparable. Okay. It's very active question in the chat, the question of efficacy of vitamin D in COVID-19. What is your position among the experts? And I want you and Rina both answering that. Well, speaking about the vitamin D and the efficacy in COVID. Well, by the way, this question has already been raised in Moscow Hall, and actually we already discussed it many times. And actually, there were already several interesting European reviews in European literature, because recently I scrolled PubMed about that. Actually, the common position is that if we're already sick and we started taking vitamin D, so how is something can globally change? And there is another piece of information that those patients who have normal level of vitamin D, that means saturating doses, and they have normal vitamin D, they have, let's say, fewer side effects. So they normally have milder course of COVID-19. But again, that is also at the level of expert discussion, no trials and no systematic data. This is simply not available because this pandemic started quite recently. But the position is that to take vitamin D and to have normal level of vitamin D is better than nothing. I'm just quoting one of the recent publications that I read about it, that vitamin is better take than not to take, because there are no disadvantages, but there are just advantages. That's the position. Yes, thank you. Can I add on, please? Well, speaking about vitamin D, that's pretty interesting, because this is D hormone and it acts not only on the bone tissue, but also it is effective in the prevention and even in the treatment of several diseases. But speaking about viral infections, I can say the following. This D hormone facilitates the increase of particular anti-inflammatory proteins. So there were few meta-analyses which showed that in patients with sufficient level of vitamin D, we reduce the risks of respiratory viral infections, including flu. So there were two meta-analyses that actually proved the efficacy of vitamin D additives. So speaking about new coronavirus infection, definitely not yet meta-analysis, but several publications are already available. It appeared to be that in patients with the deficiency of vitamin D, we more frequently observe positive dynamics in case of coronavirus infection, in case of vitamin D deficiency. That is why I believe that, in fact, the topic is really very interesting. And I totally agree, Grigory, that when coronavirus infection has already happened, probably it's too late to start taking vitamin D. But maintaining the sufficient level of vitamin D is actually extremely important in order to be protected from viral infection. And probably that's reasonable recommendation. Okay. Thank you very much, Irina. Everybody was interested. So everybody is wondering what is the duration of drug treatment. Drug holiday just for bisphosphonates. Only here we can speak about drug holiday. In fact, bisphosphonates accumulated in bone, and if we stop bisphosphonates, so it's still there. Speaking about the denosumab and the drug treatment should be continued. Drug holiday not acceptable. If we reach good parameters of bone mineral density, then after that, for 1 year, we should give bisphosphonates to fix the effect, and then possibly for some time stop treatment. But I repeat it once again, patients should not let go, because we have not cured osteoporosis. Osteoporosis is a chronic disease. That is why we simply continue following up and monitoring. So normally it's once a year when we repeat the cytometry, then 1 year later we measure, let's say, markers of bone resorption. And if there is increase of bone resorption markers or the bone mineral density is reduced, then definitely we need to go back to osteoporotic treatment. Thank you very much, Irina. And another question that is also to you, which is also about the tactics. And here our colleagues is asking, when we administer Proly after the normalization of bone marrow, it is recommended to have bisphosphonates in order to avoid a rebound effect. So any preferences among specific bisphosphonates, or maybe they're having the same efficacy, approximately the same efficacy? Well, according to the clinical guidelines, most frequently we should administer alendronate. So normally this is peros bisphosphonate alendronate. If there are some GI-associated problems, then you can take single injection of zoledronic acid, but the intervals are different. Alendronate is administered in 6 months after the last injection. Then zoledronic acid, as I said before, is administered not in 6 months, but with a longer interval, approximately in 9 months after the last injection. And I think that's it, yes. Okay, thank you very much. And also we have another comment here. What deviations of parrot hormone do we see with the long-term treatment of Proly? Irina, maybe you would like to start, and then I could provide my comments. Well, I think PTH, I don't think we can see changes of PTH with Proly. I think it's not possible due to the mode of action, but deviations from PTH can be because of deficiency. I think so. That means development of the secondary osteoporosis with the deficiency of vitamin D. So when you administer parenteral forms, it refers not only to denosumab, by the way, but specifically to such strong bisphosphonate like zoledronic acid, we should check first the level of vitamin D and definitely correct it. And in those cases where we cannot do that, but it's still recommendation of the Russian Association on Osteoporosis, so for about 10 days, at least 10 days, we should administer vitamin D, cholecalciferol, pretty high doses, about 5,000 units per day for about 10 days. All right, thank you. Any comments or? Well, I totally agree with Rina. There is no influence to PTH and the changes we see in PTH. Well, sometimes it's secondary hyperparathyroidism with severe deficiency of vitamin D. Possibly you administered and you didn't check it and you started checking it during the treatment, and these changes of PTH with denosumab probably not quite correct. So these changes with denosumab and vitamin D is a must, in order to increase the efficacy of treatment, and also it refers to bisphosphonate and denosumab. And most important, if we talk about the routine practice of what we see in reality, then patients have fewer side effects and they tolerate better zoledronic acid injection for a gram, for example, where we frequently see these adverse events with normal level of vitamin D. But in case of deficiency of vitamin D, we see more frequent adverse events. So vitamin D is a must for us. And this is how this analysis is included into the guidelines as a baseline test before the start of treatment. Well, thank you very much, distinguished experts, for this answer. And I believe that this is a result of the real practice. And most probably now, doctors do have clear understanding and good interpretation of this parameter. Final question for today. Final question to today. About high doses of steroids. Continuation of Prolia, with continuation of Prolia. There is a question here whether the long-term administration of high dose of steroids for about 14, 16 days, any risks for sudden low energy fracture? And I think this is also COVID-associated question, because currently these high doses are taken by our patients. Yes, I would like to take it. Well, about steroid-associated osteoporosis, it is not developing when we use short courses of steroids. So what we normally use for the treatment of exacerbations, the disease of lungs and the parenchyma, when can it be dangerous? When we use short courses, when there are lots of them. That means 4 or more short courses of systemic steroids a year can really lead to the increased risk of adverse events, such as we see with the long-term administration of systemic steroids, not only osteoporosis, but also other complications. This is steroid diabetes, etc. Speaking about this recommendation with coronavirus infection, 14, 20 days, well, I think no. If with that the systemic steroids are done, then I think steroid osteoporosis is not possible. It's not simply possible. Okay, thank you very much. Any comments? Well, if that was the last question, I would like to thank Irina for this joint virtual session, and you, Vladimir, for great moderation of all 3 days, and also our audience for very interesting questions, comments, remarks, and for being with us in our osteoporotic session. Yes, thank you very much. Thank you for being with us, and enjoy your break. We would like to thank our moderator and our audience for very interesting and multiple questions. All right. Thank you very much, dear experts. I think I will provide common position if I tell you that that was really practical, very valuable, and very important symposium, because today we raised very interesting, very hot questions on the curation of patients with osteoporosis. And what is also very important it actually supported by the data on new coronavirus infections, and we received multiple questions on that, and our experts could effectively comment on that. So, with that, distinguished colleagues, we wrap up this symposium, which was devoted to the issues of osteoporosis from theory to practice. And now, let me announce the next session before we go for break. I think this is a really eagerly waiting symposium because it is devoted to the issues of the primary care in the period of COVID-19. This is emergency care. And I hope that multiple questions that can be raised in that symposium after the break, after the very short break, definitely deserve some attention, because we are all not ignorant. We are all passing through this period of coronavirus pandemic, and we all need to provide most adequate, most relevant, most effective care to our patients. So, dear colleagues, before the break, so once again, I would like to announce that we are waiting for unique presentations. So welcome back here, 3:45 St. Petersburg Hall, and enjoy your break.
Dear colleagues, I would like to welcome you again in the hall of St. Petersburg. And you see the spear of the Peter and Paul fortress, you see the disconnected bridges, but we are here not to discuss architecture of St. Petersburg. We are to discuss one of the most interesting subjects that are interesting today. This is first aid and emergency aid during the pandemic of COVID-19. COVID has changed our work, has changed our conditions, and has changed the professional forms. And I would like to start this symposium by giving the floor to Valery Kadyshev, who is representing Moscow. He is candidate of medicine. He is the head of the organizational department of first aid in the Evdokimov Institute. So his subject is clinical characteristics of skin rash in patients with COVID-19. So you are welcome. Thank you very much. Good afternoon, dear colleagues, dear guests. I would like to present the presentation on clinical characteristics of skin rash in patients with COVID-19. You know that skin usually represents the general status of the patient's health. The skin lesions is a symptom of many diseases. For example, such diseases as rubella, measles. In other diseases, it can be also present. Here I show you the structure of the skin and the process that are taking place in order to understand the material that I'm going to offer. Based on the traditional understanding, here we see that a rash is affecting all the layers of skin because of histamine like drugs. So, and here you see the mechanisms that take place. First of all, the extension of the capillary network. This is the stasis of blood. This is the development of hemorrhages and edema, necrosis of epidermis and the deeper layers of the skin, dystrophic changes of cells, and it may end in the formation of the inflammation of all characters. The most difficult thing for a doctor is to assess the character of the rash. And usually we divide it into primary elements and secondary elements. Here I am showing the stages of the development of the rash. The element itself, the element of today, that is caused by the RNA virus, the gate to this disease is the epithelium of the upper airways and the epitheliocytes of the GIT. And at the beginning of the infection, it damages the cells with the ACE receptors of second time. And these receptors, you see, they're allocated on the cells of the respiratory tract, kidneys, bladder, in the central nervous system. These receptors are also available. And then these organs are affected, which is characterized by the clinical manifestations that in the debut are characterized by the acute feverish state. What it starts with? It starts with cough, with fever, the chest congestion that is very often observed in many patients. it is dyspnea or shortness of breath, weakness, and hypoanosmia and dysgeusia. So in some percentage, we also see symptoms connected with the affection of the muscle tissues, of hips, vomiting, diarrhea that corresponds to some stages of the development of this disease. And of course, we should focus on a very important symptom. It is blood and spontaneous heartbeat. This is a very important symptom that has been described very much. So the most spread clinical picture of COVID-19 is observed in bilateral pneumonia. But sometimes patients develop an acute respiratory distress syndrome. So we, of course, we study all these issues. We analyze the information that we have collected for this year. And I must say that COVID-19 has a certain influence on many other systems of the body. And at the present time, very many studies have been made in China, for example, where they formulate the data of the study. Still, now more and more they speak about the skin pathologies, which are also very important. And the reason is the infectious genesis and the affection of vessels of different size and the appearance of hypodermal process that appear in the skin. And there is a very high risk of the development of acute allergic reactions due to the combined antibacterial therapy. So I would like to show you some clinical cases. This is a confirmed COVID-19 and make an accent on the skin lesions. So that's what we see when our mobile teams visit patients. And so you see, this is the infectious genesis that I have already mentioned. And of course, they have viral etiology. Here you see acrodermatitis in a COVID-positive patient. It might be one of the manifestations of this infection. The leading link here is the lesions in dermal process. It is all connected with vessels. Pathogenesis of the slide is connected with the lesions in the vascular walls combined with antigens, anti-drug antigens. So we have seen it very many times in literature, speaking about the necrosis of the cells and thrombosis in the pulmonary tissue. We would like to say that the same picture is observed in skin vessels. And I will illustrate some of the statements that I have made. Here we see hemorrhagic angiitis. Here you see the picture, and this is the reaction of the drugs. The photo in both patients. Here you see two patients with distal limbs. They were COVID positive. They received combined antiviral therapy, 2 drugs, and that's the picture we saw. a very interesting clinical case. This is a 19-year patient who got a therapy for COVID, confirmed COVID-19. There were hydroxychloroquine and interferon alpha 2b. On the 9th day of the disease, he was a spot in the first toe of the left foot. Here it was a pink color. So here we see endomatosis lesion. This is only one case, but we see very many cases like this in our practice. Another case I would like to present, this is papulovesicular rash that this patient took the alpha-ferron alpha-D intranasally, and we see the appearance of papulas on the chest, on the neck. They are also on the back and all the limbs. It all arose on the second day of the disease and the use of drugs. At this point, we see the patient with the papulovesicular rash that was refractory to the antihistamine drugs. The second slide is similar to the first. It is also associated with allergic reactions that reminded varicosole elements that reminded the chicken pox. So the team decided that these patients in the amnanases in childhood or in mature age had chicken pox. This is intradermal development of the vesicular rash. That's how it develops. But if we look at the other clinical case that we observed in a 30-year man, he had muscular pain in the back. He took antiviral drugs, Indaverine and alpha-2b intranasally. On the 5th day, he saw this rash on the abdomen, on the back. So we see papular vesicular rash. It is quite developed. It is quite expressed. We see that it is itching. And the second patient who has the same clinical picture of this vesicular rash with the similar antibacterial drugs against the intranasal interferon antiviral drugs. So we see that at this point, the slide shows genesis and the position of this vesicular rash and the way this vesicular rash looks. That's the clinical case that we have seen, and it is quite a young patient. The next case is a papulosquamous rash, reminding of the pink rash. Yeah, so the woman had hypertension. She had COVID for 10 days. Hydroxychloroquine, she took andromycin. She also received interferon alpha 2b. So she take anti-feverish drugs, and so she noticed such itching elements, the diameter from 1 to 2 centimeters on the chest, on the back, laterally in the lower upper limbs. And as to the classification of our colleagues, included such an element. This is one of the forms that we observe. Another clinical case is connected with papulosquamous rash that the patient is 33. She is COVID positive. When she received hydroxychloroquine therapy, she saw a very, we see a very characteristic type of peeling. After this peeling, we see these brown spots that are not itching, and that was a very interesting development of the disease. The next case, this is a measles-like rash that was demonstrated. The patient is 44, against obesity, asthenia, the myalgia and fever for a week. On the 7th day of the disease, she found macular populous rash on the back, on the chest. They were not itching. They appeared all simultaneously. She took antiviral and fever-reducing drugs for a week. In the anamnesis, she had not suffered from any allergic diseases. She had not any allergic reactions to drugs or food. But this measles-like rash, here you see quite large elements which are not etching, and there is no staging of rash that characterizes such infectious disease as measles. That makes it different from the measles rash. The next case I wanted to show to you, it is toxicodermic rash as a reaction to the therapy the patients get. Of course, this therapy includes antibacterial, antiviral drugs, antiquinolones. So the patients did not have any allergic reactions in the anamnesis. And the toxidermic rash is the individual intolerability of patients towards the drugs that they were given. You see, the situations are quite similar. You see spots. Some are pink. They are merging on the belly into large lesions. There is a slight itching. The patients are suffering from, and but they are refractory to hormone therapy and to histamine therapy. One more case on the right, it is toxodermic rash, and we see a very clear picture of purple color. You see erymatose elements that are a reaction to the antiviral therapy, levofloxacin. A very interesting case of the armpit rash on the leg. The patient is 68 with COVID-19. He has dry cough, asthenia, and hydroxychloroquine. On the 12th day of the therapy, he showed bright pink rash that you see it is in the form of folliculus, and it is painful during palpation. And he saw he had it in the groin as well. And one more interesting clinical case. It is a large spot rash of the urticaria type. She developed it on the 3rd day, and this itching rash appeared simultaneously. It is in the upper and the lower limbs. We see very many large spot elements that are merging in the field of the ankle and the arm. The next case I would like to characterize that it is included in the type of this skin rash. This is the exacerbation of chronic dermatitis. This is the papular rash with maceration. And so these diseases appear during different diseases. And can be also explained by the long wear of gloves or masks. This is a systemic reaction which we observe during the COVID. The patient 36, no allergic diseases, no symptoms of COVID-19. She developed the itching rash on the right part of the slide. So the local antiseptic means were used. 2 days later, she showed COVID-19 infection. And on the 4th day, we see lesions of such maceration that are merging into larger papules. So, and of course, she has a very unpleasing feeling because the sky is dry and she cannot bend her wrist. So on the central and the left slide, we see the appearance of erythematous spots, which after 3 or 4 days disappeared without any trace, without any clinical manifestations. And in conclusion, I would like to show trophic disorders, the trophic lesions and artificial lesions of the skin. We observed cases our mobile teams observed such cases and took patients to the intensive care unit. We see very large spots. We see some desquamation of epithelium. We see congestion. Congestion. Here we see the temperature sensors which were used and which showed what kind of elements appeared later. So I would like to say that the clinical cases that I have shown, they were described and published in the archive of the internal medicine. I would like to say that this subject, the appearance of new skin manifestations during COVID is very important. And I think that in conclusion, I would like to say that the skin rash can be the first manifestation of COVID-19, but they are quite various. They have a different morphological character. They are not systematized. That's why probably it is too early to say whether they are an evidence base for the clinical manifestation of the COVID-19. So the picture we have shown will be fit into the electronic atlases for the study of this syndrome. And in conclusion, I would like to thank to the doctors and paramedics of the mobile teams and their professional interest that helped us demonstrate this rare clinical cases. And this the description of these cases is the result of the consultative work of the entire team. Thank you very much for your attention. Thank you. Thank you, Valery Alexandrovich. This is a very valuable practical presentation, a fantastic photo archive, very interesting pictures, and I think that will be of great help to all those who were listening to you. And the main conclusion we are supposed to make is that the new COVID has a lot of skin masks. And the next speaker, he's also from Moscow. It is Peter Davidov, who will speak about the practical. Dr. Davidov is representing the first aid station named after Puchkov. He is a reanimatologist and anesthesiologist, and he will speak about the practical application of capnometry in the conditions of pre-hospital stage. Piotr Alexandrovich, do you hear us? Good afternoon, dear colleagues. We see you. We see your presentation. Please switch on the sound. My sound is on. Do you hear me? Do you hear me? Please, technical support. Just a moment. You don't hear me. As far as I understand, Piotr Alexandrovich hears us, but we do not have any feedback. No, we have some pause. The question is to Valery Alexandrovich. Can we discuss it with Valery Alexandrovich? Do you hear me? No? Yes, I'm all attention. I'm all attention. Thank you, Valery Alexandrovich. There is a question. Does the skin rash require any special treatment, or we assume that the elimination of COVID-19 and rehabilitation will make this skin rash go away? Thank you for your question. Do you hear me? I would like to say that the therapy on the basis of pathogenesis, I would say that refractoriness to antihistamine drugs is very high. If we speak about the diseases, some chicken pox-like diseases, they are very resistant to the drugs. But glucocorticosteroids, for example, for various dermatose rash, they can be used because the resolvement takes place very quickly after 48 hours of the use of these drugs. But the pathogenesis is the immune complex basis, and that's why there are very many elements that make a contribution to the formation of this picture. So, but the resolvement of the skin syndrome takes place rather quickly if we use proper drugs. And since some technical work is being done, one more very interesting question. Have you had cases with the confirmed COVID cases with skin rash? And is there manifestation? Can the COVID be manifested with the rash? You know, in case of negative results, we saw allergic diseases, and there were many cases. Yes, the temperature was normal, and COVID was negative, and they were very easily corrected by antihistamine drugs. You know, but if it was urticaria, then hormone drugs together with antihistamine gave a very good result during the first day, and then oral drugs of the histamine RAO were given. But to speak about some stage of the skin syndrome in this infection is too early, because the question of the infection is being studied, is being analyzed, is being complemented, and we need some systemic approach to compiling such an archive document connected with COVID and skin manifestations. So the problem requires a further study. But we have demonstrated that, the manifestations have a different pathological character, and we don't have a clear idea about the staging of the skin syndrome. We are just keeping an eye on it. So it seems to me that the technical problem has been solved. Petr Alexandrovich, do you hear me? Do you hear me? Do you hear me? Do you hear me or not? Again, the sound disappeared. Where is our technical support? What are the prospects? Dear colleagues, I suggest passing over to the next speaker. And the next speaker will be Alexander Bezemyanny, who is director of the organization of the Moscow Health Care Department, and he will make a very interesting presentation. He will describe how the work of outpatient city centers is organized. Good afternoon, dear colleagues. Do you hear me? Yes, we hear you well. I think it is a very interesting conference. I have been participating for the second year, and I would like to thank Professor Rutyumov. I would like to thank colleagues who have spoken before me. So Valery Kadashev's presentation was very interesting. He has a lot of practical experience, and he himself is part of the mobile team, and most of the pictures have been made by his camera. But today we shall speak about the organization of outpatient CT centers. It is an interagency structure that unites the work of the outpatient care. The outpatient CT centers are organized on the basis of city outpatient clinics. And a very important aspect is the interaction not only with polyclinic doctors, but also the interaction with the mobile team members, with the first aid and emergency ambulance personnel. I would like to remind you that in March this year, the incidence of COVID was growing. First of all, we speak about the acute respiratory diseases, ORD, and we considered each patient with ORD as a potentially COVID patient because this infection could worsen his state. It is important to understand, though, for hospitalization, we had certain criteria in the laboratory and in the first aid system. When we understood that the patients with COVID suspicion are so many that we won't be able to hospitalize all of them, we understood that we needed to make a very exact diagnosis. And so we thought about how to diagnose the COVID exactly, and not to hospitalize those patients that could be treated at home. We understand very well that the hospital microflora, hospital atmosphere has a negative effect on the patient. And if the patient can be treated at home, his prognosis will be much better than in the hospital. So from 16th of March, the doctors of the primary care from outpatient departments, they had about 4,000 calls a day with for respiratory diseases. At this moment, we made a conclusion that the level of incidence of COVID incidence is growing and the hospitalization is growing. So we took a decision to organize outpatient CT center on the basis of the city polyclinics, where we could make a CT diagnosis and find at least virus pneumonia. And to assess the state of the patient in general. The purpose of the CT centers was to reduce the number of non-profile hospitalizations and to improve the precision of diagnostics. So also we tried to diagnose the patients, to define the tactics of management, to differentiate diagnostics of the disease and to provide these patients with free drugs, and also to think of the opportunity to treat the patients at home. We developed regulatory documents for these outpatient CTs. And here you see that it concerns the primary diagnostics and the follow-up of patients. So all these regulatory documents were developed, and relevant changes and amendments were introduced into these documents. And meanwhile, of course, we analyzed the process and we analyzed the situation. So the entire Moscow, including the government, was working on this efforts. And of course, a lot of construction work was required to rebuild the clinics, to divide them into green and red zones, and to give the doctors an opportunity to have a rest after their duty hours. Let us look how it happened. So for 3 days, on the 10th of April, 42 CT centers were arranged. 4 days later, 6 days later, there were already 48 centers. And as the load was decreasing, the number of centers was decreasing as well. And you see that on the 22nd of July, we had only 11 centers. But now the load is growing, and the incidence is growing in Moscow, and the number of CT centers is increasing again, and now we have 22 centers. What is a CT outpatient CT center? It is part of the polyclinic that is partitioned, that is divided by this, separated by the special partition, and there the doctors receive those patients that have been brought by the first aid or that had come themselves after the patient gets into the CT center. So it is the appointment is made for the CT test, and all the other necessary measures are taken. The patient is sent to the CT diagnosis, and after that, he has a PCR test. Then express diagnostics includes general blood test, also C-reactive protein is being tested, and after these diagnostic measures, the patient is sent to the therapist or to the family doctor, general practitioner, for this doctor to make a conclusion and to determine the diagnosis. I would like to remind you that this year the artificial intelligence has been included into this work. And the patients were automatically sent to the relevant doctors having the CT visualization. About 200,000 visualizations have been sent through the artificial intelligence. And the artificial intelligence calibrated the results. And if the doctor, by the results of interpretation, takes a decision to hospitalize the patient, then the first aid team is called. The patient is in the special waiting room, and then the patient is submitted to this team. If some extra measures are to be taken, or if the temperature is raised, for example, the outpatient CT center has a room for extraordinary aid where the doctor and the nurse can reduce the temperature and conduct the necessary therapy. Here you see the scheme of the patient's route. So if the patients had a temperature below 38, the patient was sent home and was treated home. So the patient gets the scheme of the therapy to the patient, and the Moscow Department of Healthcare provided free therapy, free drugs, free masks, and free gloves to the patient. If patient is in the risk group, if he has the condition that requires hospitalization, higher temperature, saturation below 93%, and there are some other risk factors, then the mobile team is called and the patient is taken to hospital. We always rework and redevelop the guidelines for managing these patients, and the regulatory basis is changing, and it changes the tactics of the patient management. So the system of assessment of the patient has changed a little bit, and we also change the tactics, the document turnover. And it is very important because the patients they go to, then they are sent to polyclinics where they may be followed up. So here you see we compared the patients treated at home and the patients treated in hospitals. And we see that the more patients were left at home, less was the number of patient CT centers. Here it is very important to say, so we had 277,000 tests. Now it is more, and we have detected 158,000 cases with pneumonia, and we hospitalized only 19%, 29,500 patients. Only those with whom we had doubts or whose state was very serious. So only 19% were hospitalized. We may understand how many beds were free for those patients who really needed medical aid. And out of all detected pneumonias with the CT1, it is the majority is 100,002. It's a CT1, the largest number, and they were submitted referred to the doctors and polyclinics. Then gray is CT2, and blue and red the CT3 and CT4. Part of the patients with CT2, because of low saturation and some comorbidities with age over 65, they were also hospitalized. At the present time, we continue this work. CT centers are working overnight. If during the first wave, all CT were isolated, now part of these centers have been repaired, and part of these medical organizations are just working to split these flows and continue receiving other patients. Dear colleagues, that is all I wanted to say. I am ready to answer your questions. Thank you very much, dear Alexey Sergeyevich. I think that we will carry on the query and answer session later. And now online is Dr. Davidov with a very interesting presentation, practical application of capnometry in the conditions of the pre-hospital stage. Do you hear us? I hope you hear me. Yes, we hear you. Thank you very much. Dear colleagues, I would like to say a few words about such a method. In our country, it is not very widespread as capnometry. Capnometry is a non-invasive measurement of CO2 concentration in the gas mixture, inhaled and exhaled gas, in any gas medium that is connected with the patient, this or that. So this method is very undervalued in Russia for many reasons. Although the entire world has been using this method for a long time. In the United States, for example, this method has become routine since the 1980s, and in Europe since 1970s. In the year of 2000, this method was included into American Heart Association guidelines as an essential in any severe state, in any critical state of the patient, and in any difficult situation. connected with the shortness of breath. In 2001, this method was included into the American College of Emergency Physicians guidelines and became of the standards of extraordinary medical aid. In our country, it still remains a very narrow, specialized way of ensuring ongoing monitoring. So what is capnometry? This method is to measure the level of CO2 that generates in the body. The main source of CO2 is mitochondria. And when in case of oxidation, they excrete energy, different compounds, and also they excrete CO2 during breathing, intracellular breathing. So CO2 to excretion is similar to metabolism and is equal to some intensity of life process in the human tissues. Some CO2 is formed out of bicarbonate buffer in case of metabolic acidosis. And also there is a iatrogenic source of CO2, bicarbonate of natrium. This is a very schematic picture of how CO2 is formed, generated, and how it is excreted from the body. It shows the scheme shows the metabolic process that is important for us to assess the degree of acid excretion from the body. But we won't dwell on it. What are the methods of capnometry that are used? First of all, it is mass spectrometry, Ramanov spectrometry, infrared optical analysis, and infrared optico-acoustic analysis. At this stage, most of medical institutions use infrared optical analysis. It is based on the ability of gas molecules to absorb infrared radiation of a certain wave. The CO2 has the quality, this quality to absorb, but it is only molecules that have an asymmetric structure. Symmetric molecules of oxygen, for example, nitrogen or helium, do not absorb infrared radiation, and it is difficult to discover them by this. So when we measure CO2, the gas mixture that is tested is to be devoid of, say, for example, water, steams. It must be dry. As to the description of the method, shortly we may say that PET CO2 is the partial pressure of the CO2 in the final part of the exhaled gas, and they show the pressure of the CO2 in the arterial blood. So it is equal to CO2 in the alveolar, in the arterial blood. This is a method replacing the measurement of the acidic state in non-traditional changes, measurements of metabolism. There are two main ways to measure CO2. In the scale, it is mainstream and the side stream. What is the difference between the two? First of all, they are different that in case if a COT is measured in the mainstream, this measurement takes place by means of conducting the gas mixture through a certain adapter. And this adapter has sapphire glasses that permit the infrared beam and measure the concentration of CO2. This method has its advantages and disadvantages, and the side stream capnometry is a method aimed at the regular constant sucking of the air from the adapter, and after this gas gets into the device, the measurement takes place. So today our mobile teams, they have opportunities to use the first and the second methods, the side stream and mainstream. The advantage of the side stream is when clinical situations do not require any invasive possibility of upper airways. So this method can be used for patients who are on the mask ventilation, mask inhalation, which is very important for patients with COVID. So for those patients for whom it is not effective to make an invasive possibility of upper airways with the incubation of tracheal incubation. This slide shows main differences between side stream and mainstream of CO2 measurement. Frankly speaking, these differences are not so critical except for this red statement that the side stream is optimal for non-intubated patients. That's why during the first aid help, it is preferable. There are four main indicators that have a diagnostic value. First of all, measurement of the partial pressure of CO2 in the final portion of the exhaled gas. This is a very important parameter. We may measure the frequency of the spontaneous breathing and measure trends, and we can assess the capnogram, the changes of CO2 in this or that phase of the breathing cycle. We should note that the normal value of PET COT is well known. It is from 36 to 43 millimeters of the mercury column. The changes of the values doesn't happen at once. The organism has a lot of opportunities, have a lot of resources, and there are many factors that can influence the value of PET COC. Changes, of course, changes of the COT values are happening with a lag, with a delay. Capnogram is a graphic recording of the concentration of the exhaled and the exhaled COT, capnometry. This is the digital recording of the CO2. This is the analysis of the capnogram that is made by the team. Point A is the beginning of the inhaling phase. Then there is an interval AB, shows the movement of the air from the dead space. This interval shows the functional state of the dead space, of physiological dead space that is presented by air carrying waves. On the basis of the change of this interval, we can assess the functional state of this anatomical structure. Point B is the beginning of the delivery of the air from the air getting out of the airways. Point C shows the beginning of the getting to the sensor of the alveolar, and the point D shows the maximal concentration of CO2, partial pressure at the end of the exhale, which is equal to the content or to the of CO2 in the arterial blood. The final expiratory partial pressure is the main thing here. Capnogram also hopes to assess the rhythm of the breathing. It is very important. We can see certain trends that allow to diagnose some neurological disorders. For example, non-regular breathing rhyme and the depth of inhalatory and expiratory depth. Factors that can affect the CO2 values allow us to make some conclusions in the diagnosis that show the changes in the content of CO2. The reduction of CO2 shows the pulmonary disorders, obstructive and restrictive diseases, dyspnoea. This is the violations of the CO2 transport connected with the perfusion of lungs or the heart ejection, cardiac ejection. And it shows also the production of CO2, the state connected with the metabolism disorders or changes in the body temperature. And here we have very many pathological conditions. Also, the ratio of ventilation and perfusion may also be important. This table shortly shows when EtCO2 may go up and go down in the exhaled air. All these conditions are very convenient to be differentiated with the help of the non-invasive measurement of CO2 in the exhaled again, what else can mobile teams test? It is the ventilation perfusion ratio, the ratio between ventilation and perfusion. They describe the relation between the alveolar air flow and the blood supply in pulmonary capillaries. If the indicator is 0.0 is below 0.8, we speak about the violation of the ventilation with the preserved perfusion. But if the VQ is over 0.8, we say that this patient has the diffusion of perfusion and his volume of the dead space is increased. The changes in the form of the capnogram charges have a great diagnostic value. If the mobile team measures CO2, finds the reduction of the wave height, we may conclude that CO2 production is reduced and the pulmonary perfusion is reduced. The reasons for the reduction of PET CO2 is the increase of the frequency or depth of breath. So some washing of CO2 is happening and the reserves is depleted. It can be in acidosis or hyperventilation. It can be connected with a large number of pathological states. Embolism of the pulmonary artery, PET CO2 is reduced then blood loss, infectious dehydration, progressing cardiovascular failure, it all is connected with the reduced CO2 in the inhaled air. We can even affect the reduction of the metabolism and the effectiveness of sedative drugs. For example, in intra-hospitalization evacuation of COVID patients, thromboembolism of the pulmonary arteria, it is a very serious complication. Which is manifested at a later stage of the COVID disease. In case of thromboembolism, we see a drastic fall of PET CO2 in patients who have been well ventilated. But PET CO2 fall shows that the thromboembolism is taking place. Bronchial obstruction. Very often, the person's bronchi against COVID infection are hyperreactive due to different reasons, or there is some problem on the level of the respiratory contour. Then the capnograph shows us what kind of disease is developing in there. As to the blood supply stop, it is a rare case, but the rise to 15 millimeters and higher testifies to the effectiveness of the efficacy of chest compressions. If there is no rise, we may conclude that we are doing something in the wrong way, or the patient has some problem with the removal of CO2 from the lungs. So this method is a kind of a feedback that allows to assess the compression, the effect of the compression. The last recommendation of American Association shows that capnography is one of the most valuable methods and one of the main methods to define the factor of recovery of the spontaneous blood supply. So if intubated patients cannot reach CO2 over 10 millimeters, may be considered as an adverse outcome. So the stop of the blood supply up to 40 milliliters, up to 40 milliliters, shows that the spontaneous blood supply has been restored. Even some other factors are not so good. The rise of PET COT means either the reduction of the frequency and depth of breathing, and also it can be a positive effect of the bronchotherapy. This can be also connected with the reperfusion. Also, we should say that the PET-COT increase in the patients with the shock or hypotonia shows to the sepsis process. As to hyperventilation, it is the state that we are very much afraid of, and we need to focus on it when we see the increase of PET-CO2. So sudden hyperventilation is detected by capnograph only after a few minutes, but still from the first minute we must understand that there is some catastrophe happening. There is a lack of oxygen and the body lacks the important element. With the gradual reduction of the minute respiratory volume, the current value of CO2 shows the depth of hyperventilation or hypermetabolism, sepsis, or hyperthermia. Patients with chronic obstructive disease, the form of the curve is very important. It usually has such a shape, which looks like the shark, and it allows us it shows us that the patient has an obstructive lung disease. And the sudden increase of PeT-CO2 is connected due to, it is a very rare situation, and we may also judge about different changes taking part in the place based on the other phenomena that the first aid team can detect when they see the patients in the shock state. The conclusions may be the following. Capnometry is an opportunity to understand the process of the patient breathing on the expert level. Since very many doctor specialties are involved in fighting COVID, and given the opportunity to conduct capnometry to patients with any kinds of respiratory support, it becomes one of the most important non-invasive methods of diagnostics and monitoring of patients with coronavirus infection. And the full-fledged intensive treatment is impossible without overall assessing of the respiratory function. Thank you for your attention. I will be happy to answer any questions that are asked. Well, that was a very interesting presentation. Each of us understood it. There is no need to speak that first aid teams are people who are on the front line of fighting coronavirus, and they are to have all the opportunities to find the violations, the disorders in the gas flow at the patient's bedside. And such methods, as described by Petr Alexandrovich, of course, they really equip our doctors and nurses. Dear colleagues, I would like to nominate the session of questions and answers. We have questions to our experts. And the first question is addressed to Valery Alexandrovich. Valery Alexandrovich, what is the duration of skin changes in case of the new COVID infection? Thank you for your question. Yeah, really, the clinical cases that we have observed that they have been demonstrated, they have their unique feature, and the provision of aid. Aid was provided for the pathology for which the team was summoned. But how long is the syndrome? How regression takes place? There are some difficulties in describing it because the first aid stage has its opportunities, but it has its limitations. But you know, the repeated calls were almost concerning papular squamous squamous or chickenpox-like elements. And of course, they had a long duration up to 10 days before the regression started. But those changes that had an allergic character in young patients who were connected with epirexia and a small itching, they were resolved very quickly by antihistamine drugs together with glucocorticosteroids. As to the duration and the staging of these manifestations are difficult to discuss. That's what I can answer. Of course, there is no evidence base so far. Thank you, Valery Alexandrovich. Alexei Sergeyevich, is there any idea of the time of fibrotic changes? How fibrotic changes in the lungs, how long do they remain after the patient has recovered? You mean after he has been discharged from the hospital? Yes, in the faraway period. First of all, the indication for hospitalization is already virus of pneumonia of stage 2. It is also very important to keep an eye of the degree of the involvement of the lung after the patient has been discharged. The work is going on, but it's too early to say within what dates the rehabilitation takes place. Well, it's impossible to say. Thank you, Alexei Sergeyevich. Really, there haven't been such studies, haven't been such papers, although it's a very interesting subject about the consequences of COVID infection in the short time, in the long time perspective. And the issue is studied not only in the Russian Federation, but in the entire world. And the question to Peter Alexandrovich. Peter Alexandrovich. It seems to me, comparing capnometry and spirography, which method is more advantageous for assessing COVID-19? As far as I may say, about these two methods and the comparison of those two methods at the stage of COVID, the mobile teams see, you know, at our stage, the most important thing is to assess changes of or measurement of critical disorders in the body, and capnometry allows to judge the pulmonary failure and the changes in the gas content of the blood. This is a method that allows to deliver the patient safe and sound to the hospital. A spirography, it shows the bronchial obstruction of easier. It has a fine tuning, and it allows to detect the disorders in the functions of bronchi in patients with fewer clinical manifestations of the respiratory failure. These are two methods and cannot be compared. Thank you very much, Piotr Alexandrovich. On my part, I would like to support your position. When we speak about spirometry, we need to speak about just other diagnostics and other diseases, because in COVID pneumonias, we do not see bronchitis before the secondary microflora is added. Dear colleagues, in fact, most of the questions that we have received have already been commented upon you on the stage of the presentation. And now, dear colleagues, let us thank our esteemed experts. That has been a very interesting and practical session, very interesting presentations that really armed us with new interesting data and approaches. My dear colleagues, I would like now to sum up our day today and the entire St. Pete Hall results. We have had a very interesting day. We had a Serbian symposium. Our colleagues from Serbia spoke, and we spoke about invasive and non-invasive diagnostics of coronary failure. So I think the level was very high, was very technological, and our colleagues spoke about their results, about their protocols, with whom you can get acquainted in the archive storages. Then we considered the issues of osteoporosis and we looked at the most problematic, at the most difficult problems of this disease management. And now I think we have had a very interesting symposium related to the first aid in the conditions of COVID-19. At the same time, this is the third and the last day of the 10th Jubilee Congress and it was an outstanding congress by coverage because over 90 speakers have presented their presentations from different countries. So doctors from 12 countries have been involved and taken part in the symposia and seminars. It seems that the Congress was a great success because the number of connected doctors was very big. And the range of problems the Congress discussed is impressive. It seems to me we have covered all the sections of the internal medicine, and the most prominent specialists have expressed their opinion. I think it is a very important sign of Euro-Asian Congress is a focus on the practical approaches that the organizers always imply when they make up an agenda of this Congress. It's important for the future and for the work that we will do with our patients right after this Congress. The colleagues, calling it a day. I would like to thank everyone who found time to get connected, to ask questions, to take in the presentations of our speakers. I would like to thank our speakers, our experts who put their heart into their presentations and made them on the highest up-to-date level. And I would like to thank the team that prepared the Congress and during the Congress supported the speakers. These are the people we don't see, but they have really made a lot contribution to the success of this Congress. And I'd like to end and say that our Congress is in an online format, and this format has a limitative character, which is caused by the pandemic situation. Our medicine, our industry is a non-stop cycle. For 3 days that we have worked, our colleagues were in the red zones, worked with infectious patients, and it is happening today, and it will happen in the near future. On behalf of the Euro-Asian Association of Therapists, I would like to pay tribute to these people, because working in such conditions and fulfilling their mission is very, very difficult. Dear colleagues, we decided to show to you again this clip devoted to the work of our patients in red zones. And it was, by the way, made by those doctors who are working in red zones and know what it is like. I'm saying you goodbye until the next 11th Congress of the Euro-Asian Association of Therapists. Thank you for your attention. Goodbye.
Труд в медицине, поверь, не мед. Славы в ней нету и нет банкнот. Только готовность помочь всегда. Нас вспоминают, когда беда, беда. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха, и нету воздуха, давят очки, и рот пересох. Но ты же знаешь, зато тебе с небес улыбается Бог. Слились работа и сон в свой круг. Слились работа и сон в свой круг. Редко проводим с семьей досуг. Редко проводим с семьей досуг. Но тяжелеет больной, и вот тяжелеет, и вот долг наш врачебный опять зовет, зовет. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, но стоим. Сутки без роздыха, и нету воздуха, давят очки. И рот пересох, но мы же знаем с тобой, что нам с небес улыбается Бог. Со смертью идет война. В каждой победе своя цена. В наших сражениях всего трудней. Что мы теряем коллег, друзей. И снова кажется, что смерть куражится, выиграв опять кого-то из нас. Но свой исполнив, он вдруг по наклонной тихо угас, тихо угас. Горе прибавится, что нам останется лишь третий тост. На тягостный вздох мы точно знаем, что им там в небесах улыбается Бог. Мы точно знаем, что им там в небесах улыбается Бог.